and record. There we go. So good morning, everyone, again. I just wanted to thank PHACE for sponsoring our meeting. We really appreciate the support that we can get to be able to bring meetings like this to our patients. We are based in the USA, but we do help families globally. And so it's really important to have the support from everyone and other companies, particularly PHACE, to help bring us together. Here's Dr. Drolet. We're going to admit her. So what we're going to do is I'm going to introduce Ann Buneo. She is our president, and she is going to open our meeting and share a little bit more about her as well. So I'm going to stop sharing.
Good morning, everyone. Greetings from upstate New York. Hello, my name is Ann Buneo, and I have the honor of being the recently elected president of the PHACE Syndrome Community Board of Directors. I would like to welcome you to this year's annual virtual conference, take some time to introduce myself, and share with you the results of the 2024 PHACE Syndrome Community Member Survey. Before we get started, I want to welcome our new board member, Erin Perry. Erin is a board-certified registered nurse. She's a care manager. Her younger son, Connor, was born in 2013 and diagnosed with PHACE syndrome. He is planning a Race for PHACE virtually in the Chicago area on September 15th. I just wanted to plug this big event for the year. It is a great fundraiser that helps us raise funds for research so we can learn more about PHACE syndrome. And the event will take place there in the Chicago area and also virtually. So I ask that you would please take a look at the PHACE Syndrome Community website for more information and to register and show your support. So we are thrilled to have Erin Perry on the board, and we look forward to working with her through the next term. I also want to take a moment to thank our speakers today. These brilliant doctors help the community understand PHACE and lumbar syndromes better and guide patients on their treatment plans and help them and their families deal with this rare illness on a daily basis. I also want to take a moment to thank Paul Butera for his tireless efforts, wisdom, and guidance as president over the board for the past few years. And I'm also very grateful that Paul is remaining with us on the board to serve on the finance committee. And last but not least, I want to thank all of you for taking time out on a Saturday to be with us as we learn and share about PHACE and lumbar together today. I know 4 hours is a lot to ask. There are family commitments and personal things that need to be done. So I really appreciate your time and your effort today. Now, I would like to tell you a little bit about myself. I am originally from New Orleans, Louisiana, and I spent many years in Dallas, Texas, where I earned a bachelor's degree in international relations from Texas Christian University. I then went on to receive a master's of business administration from the University of Dallas. And currently, I am the high performance computing product leader at GE Aerospace, where engineers, thousands of them around the world, use our supercomputers to design and perfect jet engines for commercial and military use. They're also inventing the future of flight. So one day, we hope to be able to fly you from New York to Dubai in 3 hours. Just wait, we'll do it. As I said, I live in upstate New York with my husband, Jason, and our 12-year-old son, Charles. The reason why I'm telling you all of this is that I am an adult with PHACE. I was born in 1977, 19 years before Dr. Ilona Frieden described the collection of clinical characteristics that we know as PHACE today. Throughout my life, I'd seen many specialists to get a better understanding of my laundry list of medical issues and to receive treatment for them. I endured all of the things you and your family members have endured as well. People looking at me, people looking at my parents, having doctors not understand or not know what my future would be like. And as I just described to you, my life has been great and my future looks very bright. My face was completely covered on the left side with a very red hemangioma. The top of my head, my neck, and today you can still see a few remnants of it on my neck, in my ear, and around my eye. So all these doctors, they just treated all of my symptoms. They told me things that my coarctation of the aorta and my hemangioma were completely unrelated. It wasn't until a very thoughtful primary care physician whom I saw when I was in my late 20s asked that I see a cardiologist to figure out what was causing this heart murmur. By happenstance, I figured out that my aorta was indeed coarctated in two places. So I happened to Google. Dr. Google told me about coarctation of aortas and hemangiomas. And the first thing I saw that popped up on the screen was the PHACE syndrome community. And I'm so grateful for the organization for putting me in touch with Dr. Siegel and starting me on a path to better care, better understanding, and helping me gain some stability in my health. And while every single PHACE syndrome case is unique, I am doing well at 47 years of age. And I look forward to helping other adults and children and families affected by PHACE. And earlier this year, I want to let you know that the board of directors of the PHACE syndrome community have taken the needs of our members very seriously. So we revitalized the annual member survey so we could compare results and truly understand where we need to focus on our strategic plan. So this strategic plan will inform our activities in the coming years and help make sure our members are getting what they need. So I would like to share with you the results of the 2024 member survey. Our goals for the survey were to ask questions around these themes: people's experience with PHACE, their PHACE syndrome community involvement, and areas where the community can improve in carrying out its mission. We also wanted to find information to help us determine where we should focus for the future. What more information do people need? And how can we serve the community better? There were 66 questions. Thank you to those who answered them. I realize it was quite a lot, and we are going to reduce that for next year. We do not want it to be a burden, but we want to understand how this organization can evolve so that we make great strides in supporting people with PHACE and funding research. We had 72 respondents, which is statistically significant. We had opened the surveys between February and March of 2024 and performed analysis on the results. Our respondents were from all over, including someone from all over the United States, I should say. And we had one respondent from Australia. And this tells us, and we've heard this before, that we need to figure out how to do a better job of helping our community members outside of the United States. Our respondents were mostly white and Caucasian. And we saw representation from the Black or African American community, Asian Pacific Islanders, Hispanic, and those who also identify with multiple ethnicities. So who were our respondents? Well, most of them, surprisingly to me, were adults 18 years or older with PHACE syndrome. A lot of them were in their young 20s. And I was pleased because as an adult with PHACE, you feel like a bit of a unicorn. So I'm happy to see that my other unicorns are out there in the wild with me. There are also many parents or guardians of individuals with PHACE who responded as well. There were some children with PHACE who answered the questions, and a few family members or friends of people with PHACE, which is great to see because there's probably a lot of love and care in our community as well. And I also wanted to know, did they ask about the registry? So we find out about people and help them get connected to research and further the research causes. A good majority of them did know about the registry. And so we will go deeper in promoting the registry so we can decrease the number of no's and not sure's. We wanted to learn more about people who are affected by PHACE, those that people responded about in our survey. We have the ages of the people with PHACE, and you could see, as I mentioned before, many of them were in their 20s. Some were teenagers, infants, preteens, 30s, toddlers, elementary school age. And we will use this information to target programs and events for our different age groups to bring people together, to have some fun, to learn together, and really build that sense of community. Our friends and community members with PHACE have these attributes, with the arterial anomalies being the most common. PHACE and the different letters associated with PHACE are not the only things that we experience as PHACE patients. There are other comorbidities that we also deal with. We have to be treated for, we have to take medication for, get imaging for, and manage on a daily basis. So we see a significant prevalence of hypothyroidism and hypertension. We see learning challenges in autism, endometriosis, mobility issues, migraines. I was surprised to see that ranked low. I mean, not low, but that's an area where we want to focus on attention as well. And personally, I remember experiencing my first migraine at age 5. So that's another thing I can empathize with. And then we also had some other self-reported items, mental health issues, especially anxiety and depression, and other physical elements like motor skills.
And can I just interrupt real quick? I'm getting some messages that on your screen, it says live captions and subtitles. I think you should have to hit got it because some of it is blocking your presentation. We want to make sure we can see all your screens.
Oh, thank you very much.
Okay.
I did not notice that. We asked a number of questions related to the PHACE mission. The reason why we exist is to raise awareness, first and foremost, about PHACE, to build a community for all of those affected, to support each other, to support research, and to be a source of medical information, and also to publish latest advancements in research. So how have we done so far in living out our mission? Well, we can see that we've done pretty well in most of the categories, but I still see double digits for the FAIR rating. So of course, we want to dig deeper into that to see if we can move up our efforts closer to the excellent and very good regions. So we'll be looking into understanding that why that occurred and what we can do to improve those areas. We also asked about members' information needs. What areas should we focus on to provide better information? And we all want to know the cause of PHACE syndrome, right? How did this happen? How can we prevent it? How can we have early detection, if that's even possible? What is our long-term prognosis? Yes, I'm doing well 47 years, but what is my life going to be like at 90 or at 100? Because I do expect to live to 100, at least I want to. What are some treatment and management strategies for the things we experience now, and what can we prevent for the future? What is the impact on development and growth of our brains, especially when it comes to those arterial anomalies and ischemia? How can we get treatment for and improve our vision and hearing problems, our head and neck malformations? And then how do we address our own anxiety, mental health issues? What is the impact of PHACE on mental health, besides being a person with a chronic illness that they have to manage on a day-to-day basis. We asked our members what they expect of us as the FACE syndrome community. And then that way we will know better whether or not we're meeting the community's needs. Again, time and time again, providing more information is vitally important to them. Families and patients want to understand the causes, symptoms, treatment options, and the prognosis. What does the future look like? They want to have detailed yet easy to understand information about FACE syndrome, and they want to learn the latest findings of research. This is especially important because many of us have the similar experience of trying to educate all the specialists we see about FACE syndrome. If you're lucky enough to get a copy of the little book that came from the University of Wisconsin that gives great information about FACE, you go to your appointment, meet your new dermatologist, neurologist, cardiologist, endocrinologist, orthopedist, and you say, I have FACE, and here's what it is. They look at that book and they say, this is great. Can I keep this? No, you may not. Prized possession. And so we need to help our families and patients with that whole process of educating their physicians, because this is such a rare illness that I don't believe it gets much attention in medical school, as there are many other rare illnesses that do not receive the attention they deserve. We also want to create connections so people are able to share their experiences, get to know each other, support each other, and compare notes of what it's like to get through this. And also help patients find research projects where they can participate, so we can find out more information. It sounds kind of strange, but I'm hoping I'm going to lose a tooth one day so I can mail it in, so I can learn more about my dental issues. Not really, but if I do, I will mail it in. We also wanted to know more about how can we increase our members' participation in research involvement. And so if we provide more information about what research is happening, what research projects are coming, we can help make those connections and get people registered and involved. And also, you know, if we can have our physicians and researchers stay in touch with us, so we can meet and provide more information about what is happening in the research space, that is also greatly beneficial for our community members as well. So our members ask the researchers to make these their research priorities for the near-term future. So migraines, the causes, the treatments, the prevention, all of those things would be immensely helpful. And knowing things like, and making sure people are aware that triptans are dangerous for us. So what other options do we have? The risk for cerebral and cardiac aneurysms. Will my aneurysm stabilize forever? I'd love to know that. Arterial anomalies and stroke risk. What can we expect for the future, as I've mentioned before? What complications and outcomes could occur? As children get older, what can they expect as they develop and grow? Etiology and pathogenesis, fancy words for how does this happen in the first place? Treatments for hemangioma, cognitive impairment, the cause of those issues, seizures, sternum issues. The sternum, the S at the end of FACE syndrome, is a topic that is neglected sometimes. Endocrine issues and abnormalities, hearing issues, quality of life, and mental health. We ask that hopefully that you will explore these options, and we will do our very best to help raise funds for research to enable you to do that. And with that, I'd like to ask the group if there are any questions. Okay, thank you very much then.
Thank you, Anne. Okay, awesome. Those surveys are important, so we do ask when you see them. Probably annually, right? Then we will ask that you fill them out because you can see there was a lot of great information and it does help our doctors know what's important to the community as well. Okay, so next up, we are going to Dr. Drolet, I think you're up on the agenda. I think I have to have you who can share. Yes, I can share when someone else is sharing. Okay, so Dr. Drolet, you should be good if you have slides that you want to share.
Okay.
Dr.
One
Drolet,
second. Yeah,
again,
just pulling up.
yeah, no, that's okay. While you're getting ready, I do want to thank the West Coast folks for getting up so early. That's it's hard when we're working with our different time zones.
Well, they're early bird risers anyway.
Exactly.
I cannot seem to share here, which I think is on my end. Let's see. There it is.
Okay, awesome.
Okay, are you seeing the full screen share?
No, we're seeing the
There we go. Okay.
yeah, there we go. Perfect. Thank you.
Perfect. Okay. Good morning, everybody. I am a pediatric dermatologist at the University of Wisconsin and have been involved for many years, actually since the beginning, with PSC at one of the PHACE syndrome meetings that we held in Milwaukee. A group of parents decided to start this community, so I have a long history with this fabulous group and really honored to be here today. I want to just put in a plug for a group that many of you may not know about, but there is a subgroup of pediatric dermatologists who were very interested in studying hemangiomas. And I don't know, Ilona, what is it, 24, 23 years ago, we formed a group called the Hemangioma Investigator Group. And this fluctuates between 10, 11, 12 sites of folks meeting twice a year, discussing so many issues with hemangiomas, PHACE syndrome, lumbar syndrome, and treatment of babies with infantile hemangioma. So this is a really old picture, but we just came back from our national meeting where we had a retreat. So strong organization really supporting the research of all children with infantile hemangioma. So I was asked today to speak about treatment of the hemangioma itself and specifically about the use of oral propranolol for the treatment of infantile hemangioma in babies with PHACE syndrome. So what I'm going to do is just very quickly go over some historical treatment options, walk you through how and when we started using propranolol, and some of the things that we've done to make sure that while we're treating the hemangioma, we're not causing other problems in babies with PHACE syndrome and lumbar syndrome. So as you know, hemangiomas are very common. When we see a baby in our clinic, about a quarter to maybe now half of the babies will need treatment. About a third of those will get oral treatment. Historically, we've used not very many medications. So when you think about a disease that's as common as hemangiomas, there aren't a lot of different treatment options. But for many years, we used oral steroids. There were a couple years back in, I think, the early 90s or 80s even, that we used interferon. At one point where we're using IV vincristine. And then things really changed for the better in 2008 when there was a publication describing the use of oral propranolol in babies with hemangiomas. We also sometimes use topical timolol, which I won't talk much about today, but we might have time if folks have questions. And very rarely, an emerging treatment is medication called sirolimus, which is really only used when we have complications from the propranolol or the propranolol is not working. So we're going to spend most of the time talking about oral propranolol. I just wanted to put a plug in for the steroids. So some folks might be using oral steroids. Dr. Frieden and my mentor, Dr. Nancy Esterly, described this in 1968. And much like the propranolol, the story was that a baby got oral steroids for an asthma flare, and her hemangioma got better. And so we began using this medication. And I will tell you, because I use this for about a third of my career now, it did not work very well, and we saw a lot of side effects. So we were certainly very, very excited and really just a complete paradigm shift in treatment of infantile hemangiomas when pediatric dermatologists in France noted that hemangioma was significantly improved when a baby was receiving oral propranolol for hypertension while being hospitalized. The hypertension was a side effect of the prednisone. And of course, the mother said, I think ever since we started that propranolol, the hemangioma got smaller, and the doctor was smart enough to listen to the parents and did a small study looking at using oral propranolol. So what is oral propranolol? So it is an old drug. So it got its first FDA approval in 1964 for treatment of blood pressure and for arrhythmias. It is very commonly prescribed for such an old drug. It's still around and prescribed to 7 million people in the United States today for lots of different medical uses, mostly arrhythmias, high blood pressure, thyroid disorders. It's used for migraines. It's used for post-traumatic stress disorders, so a lot of different things. And of course, infantile hemangioma. So propranolol, here's the molecular structure of propranolol. And what propranolol does, honestly, in a very simple way of thinking, and kind of what I learned in medical school many years ago, is it blocks the beta receptors. So nerves will send out epinephrine or norepinephrine, which then will bind to different tissues, which are blood vessel tissues, heart tissue, and stimulate that heart tissue or that blood vessel tissue. And when you are taking an oral beta blocker like propranolol, that molecule that I'm showing here actually kind of lodges into that receptor and blocks. So that's why it's called a beta blocker. How it works in hemangiomas, to be honest, I don't think we know. Hemangiomas do have beta receptors, but there is emerging evidence that the propranolol may work in a different way rather than just blocking the beta receptors. So this comes from a website that's called PubMed. So this is something that is physicians and researchers we use a lot. And on the axis, you can see how many articles have been published about using propranolol for the treatment of babies with infantile hemangioma. So in 2008, there was 1 or 2 articles. And then very quickly, you can see that we were seeing 30, 40, 50 articles a year really sustained over the last almost 20 years. And part of the reason that this medication got adopted so quickly, it's really an interesting history for use of medicine, particularly in a baby. One reason is it works, and it works really well, and it works very quickly. So here's a baby of mine, not with PHACE, but who had a large hemangioma with some ulceration and pain, and just had a quite dramatic response, healing of the ulceration, as well as shrinking of the hemangioma just within 3 months of therapy. So we had very rapid adoption of propranolol because prednisone didn't work very well, had a lot of side effects. The oral propranolol was commercially available. So because it was such an old drug, there was a suspension, at least in the United States, that we could prescribe to children the minute the article came out in the New England Journal of Medicine. So we didn't have to wait for the drug to be made and have an FDA approval, which usually takes 5 to 10 years. So we were able to start using it right away. And we felt pretty comfortable doing that because it had been used in infants didn't have an FDA approval for infants, but it had been used for as a standard of care for infants that had cardiac arrhythmias. And again, I mentioned it was rapidly effective. So one thing that the hemangioma of infancy, hemangioma investigator group did very quickly is we worked with pediatric cardiologists around the country, pediatric dermatologists, and came up with guidelines for use, because we all started using it and we really didn't know the dose and we didn't know what kind of safety things. And we wrote up the guidelines for treatment of infantile hemangioma. So this is something that for many years, all of us on this phone, you can see Dr. Siegel and Dr. Metry and Dr. Frieden have been really studying and looking into. I would say some of us as pediatric dermatologists know more about beta blockers in babies than some of the cardiologists 20 years later, but we still depend on them, of course, for our help. This has been revised and there's lots of different versions. So every 5 or 6 years, we become more comfortable. We learn what things we're supposed to do and continues to be sort of a living document as well. So one of the things when we wrote this paper is we really had some special considerations. And a big one was the use of oral propranolol in PHACE syndrome, or in babies with PHACE syndrome. And the reason for that, which everybody on this phone knows, or on this call probably knows, is because one of the really common components of PHACE syndrome is developmental anomalies of the medium and small size arteries of the head, neck, and chest. And so what did we see more complications or different kinds of side effects in babies that have coarctation of the aorta, or have an abnormal internal carotid artery, or have even a history of stroke, or have the dandy walker? These were questions that we thought a lot about and were very concerned. The tough thing back in 2010 is babies with PHACE syndrome always had the worst hemangiomas. And so these were the babies that needed the best treatment because it was around their eye, it was on their face. They're usually large hemangiomas. So we really wanted to use this medication. We wanted to use it safely because we knew it was so much better. So here's, I think we'll talk, everybody knows this, but the changes of the arteries in PHACE syndrome. And so one thing that we worried about, because babies with PHACE have abnormal arteries, very rarely they can have stroke. And so Dr. Siegel, Dr. Frieden, many of our HIG members, as well as pediatric neurologists, pediatric neuroradiologists, and our cardiologists looked at patients with stroke, and we tried to figure out what would put one baby with PHACE at a higher risk than another baby with PHACE. And this is really what we worried about with propranolol. So one of the things propranolol can do is decrease the blood pressure. That's actually what it was made for. So if we decrease the blood pressure in babies with PHACE, would that decrease the blood flow to their brain and they have these abnormal arteries? We all started using the medication because it was so good and so efficacious. And then the first thing that we did is we got all of a bunch of centers together, and Dr. Metry had led this and said, have we seen more complications in the babies that we've used it in? So this is a small study, and this was published way back in 2013. So, really just 2, 3, 4 years after we started using it. And at least in the small group of babies, we really didn't see more incidents of stroke. We didn't see higher incidence of other types of side effects, but very small study. One baby had some weakness that seemed to resolve that we thought maybe wasn't related to the use. So this is the second study that we did several years later, again with a bigger group. So now we sort of knew, well, there was sort of high risk and medium risk of PHACE patients. What happens if you're treating kids with propranolol that have high risk, so more abnormal arteries, or had coarctation? And so this was a group of 76 patients. Again, the same kind of way as we got everybody together in the hemangioma investigator group. And so let's find all the patients we've treated over the last years, make sure that we didn't see an increased risk of different kinds of side effects. And this, again, small study, 76 patients, but that's a lot for a rare disease. showed a really good safety signal, so that we didn't see stroke, we didn't see TIAs. One baby, again, had a little bit of weakness that we weren't sure was related to the propranolol, and we didn't see other types of side effects different than what we see with babies that we treat with hemangiomas that don't have FACE. So in these, we had 46 non-serious adverse events. So this might be something like sleep disturbance or cold hands, and then among 29 patients. And when we compared that to about 700 patients that got propranolol that didn't have FACE, that didn't seem to be different. They were the same kind of side effects at the same rate, and generally pretty safe. We did make recommendations to try to use lower doses. So perhaps if we had less change in the blood pressure, it might be safer. I still like to use the medication 3 times a day. So you give a smaller dose 3 times a day, so there's less swings in the blood pressure. And we also try to treat to response of the hemangioma. So one thing we notice in babies with hemangiomas is some babies only need a little bit of propranolol, other babies need higher doses. So we use low dose until we get the effect with the hemangioma shrinking, and don't necessarily have to go up to higher doses. Always need to have good imaging studies. And we usually, and this is important for folks on the call, is really emphasize that FACE babies or babies with FACE really need to have multidisciplinary care, which includes probably a neurologist, neuroradiologist, and cardiologist if there are heart issues as well. So I think, Maureen, I'm going to go ahead and stop here to see if folks have any questions.
Yep. Anyone have any questions for Dr. Drolet? We always say that we don't always have our doctors in front of us like this, so now's the time. No questions?
I have a question.
Oh, yes. Thank you, Whitney.
I just wanted to ask if you had an opinion on the time that children should be on propranolol. I've seen a lot of back and forth where some dermatologists are saying, oh, well, we only do it for a year and we wean off at a year. And then others are saying, oh, we keep going until, you know, we feel like it's reduced to, you know, the right size. So I didn't know if that was in the standard of care or whether that's just sort of a case-by-case decision.
Yeah, Whitney, that's such a fabulous question. I think I had that on my slide, the length of therapy, and then I took it off. So in general, for a baby with an infantile hemangioma, I would say the majority of babies we are able to get off between 10 and 12 to 13 months. Children with FACE syndrome or children with large hemangiomas, we sometimes and more often see that the hemangioma tends to rebound or grow back. So there is a lot of variability, and it seems to be much more common in the hemangiomas in children with FACE that they grow for a long time. So in my experience, I can have some children off at a year with FACE syndrome. Others, when I do that, the eye hemangioma grows back and they have to stay on until 16 months, sometimes up to 2 years, sometimes even up to 4 years. So there's a huge amount of variability, and something that we're very interested in, because we sort of think maybe there's something different about the hemangiomas in babies with FACE. It also is very anatomic location. So there's certain areas like the lip or the parotid area where we see them grow for a longer period of time. My approach, and I know Ilona has thought a lot about this, so I'll let her answer as well, is to get off as soon as we can. If the child doesn't need the drug, we should stop it. But for many kids, we see that the hemangioma grows back. So I always try to taper. And then if it starts to grow back, we restart it, use it for another 4 or 5 months, try to taper again and restart it with the goal of trying to get off the drug, but also maintaining good cosmetic and functional outcome for the baby. Ilona?
Yeah, I actually raised my hand to, I completely agree in terms of our experience. And I think Mitchell Braun, who's going to speak next, includes the fact that we do see prolonged growth, unusual persistence of hemangiomas very frequently in FACE. We see it in other large hemangiomas in patients who don't have FACE. And we don't, it's just another not unexplored, but unexplained area. The other thing I would say is that there's this fascinating, many of you who have migraine headaches or your children do, know that actually propranolol is treatment that's used for prevention of migraine headaches, which is fascinating. So it's a medication which has kind of dual purposes sometimes, and it makes us wonder about really what is propranolol doing to these blood vessels to stabilize them in some way that we don't completely understand. So that's just sort of another intriguing sidelight, I would say. But I don't think that anyone, to your question, Winnie, I don't think that dermatologists who may not be as familiar with hemangiomas, it's the rule that you stop after a year or after 6 months, which is what the FDA approval is for, is just, that's not our experience. We treat with the intent to control the situation. And if we need to treat for longer, we sometimes have to do that. Drugs that Dr. Drolet mentioned, like sirolimus, which some of us have very limited experience. We have a lot of experience using it for other vascular birthmarks, but not for hemangiomas as much. May end up, or there may be other medications we hope that will end up giving more permanent responses for those patients who do seem to have what we call rebound growth, or where the hemangioma regrows even after it shrunk. I hope that's helpful.
Yeah, that was awesome. Thank you guys so much.
Thank you, Whitney. That was a good question. I know a lot of our families have posted that in our Facebook group. Okay.
I have a question. Just because people are raising like the regrowth. So my daughter was on propranolol until 10 months. Somewhere between 6 months and 15 months, she had a TIA that we don't know if it was because of propranolol or not. She had no symptoms, but considering regrowth, I mean, is this something that we should be more concerned about in the future if it does regrowth? We thought propranolol was amazing at the time, but thinking about the future, what kind of considerations might we want to have in mind?
I would say in general, the regrowth happens in proximity to when we stop the medication. So, sometimes as quick as 2 or 3 weeks, sometimes, I would say most of the time within 3 or 4 months. So I usually say, if we can get over, 4 months or 5 months and we're not seeing a change, it's less likely, not impossible, less likely that the hemangioma will do that rebound growth. So, I mean, very rarely, probably out of, hundreds and hundreds of patients that we've seen with hemangiomas, we sometimes see this growth like at a much later stage, but most of the time it happens like 3 or 4 months after. So if Jeannie, if you've been off of the propranolol, her hemangioma hasn't like started to grow back and it's been at least 4 months, you're probably, almost out of the woods, or, kind of on the edge of the woods. That
It's 2 years. So, yep.
Yeah, great. Yeah. So yeah, it's sometimes we've seen like, I had one patient that had a basketball, on her face, and her hemangioma seemed to grow a little bit, and she was a little bit younger, but that's really, really unusual. So you're probably out of the woods since she's been off of it for a long time.
Thank you.
The other thing I think it's interesting when you have a mindset, and we all started out this way. I certainly did. I was taught that hemangiomas grow really rapidly in babies and then they, quote, go away, which I quickly learned wasn't true because it depends what you mean by go away. But because I think in a lot, as we found out, and as Dr. Braun will speak about in a minute, there is a lot of persistence, sometimes not just of scar tissue, but also of hemangioma, particularly in face patients. So when you don't accept that that can happen, then you don't see it as much, or at least we didn't see it as much. We have a article that we're working on right now with Dr. Cheryl Bayer of Cincinnati Children's, which is called Hemangiomas That Don't Read the Textbooks. And I think it's a great title because, and this really came from our experience both with face patients, but also other patients with hemangiomas. For example, I don't know how many of you who are older patients with face or have older kids, we found that, like, for example, if you had hemangioma inside the eye on the, what's called the conjunctiva, the sort of inner part of the eye, or inside the mouth, and you open the mouth and look at that, it often stays bright red the way they looked when they were babies. And that's an example of something that we know happens, but we don't know how often it happens. But there are many examples of that. So I would not assume that going away is quite the right word for what happens. They do seem to naturally, there's an attrition to hemangiomas, but I don't think that means go away in all cases. So that's, I think, something that we've learned in the last 10 to 15 years. But propranolol does help even when you're older, as many of you have experienced. But there may be better medications ultimately that help too. So we'll see.
The title of that study is amazing, and I love it so much. I did have one more question, and this might be covered in the next section. So if it will be, that's totally fine. But have we looked into or seen any experience with rebound growth with the onset of puberty? Because that's just something that a small handful of us have kind of discussed a little bit and have noticed, because I know that that's also a time where we're seeing an increase in migraines and stuff like that. So I didn't know if you'd had any experience or any thoughts on that as well.
Well, I'll let Mitchell answer when in the presentation. I don't remember exactly what the data we have on that, or if we ask that question quite the right way. But I mean, I think puberty is a time of huge numbers of growth signals that the body is undergoing. That we all know that, growth spurts, etc. And what we think is going on with the effects of propranolol is that it's not. If many of you have heard of the idea of stem cells, which are the cells of origin of everything in our body, basically, that it's a sort of self-renewing, why we continue to, have skin and it doesn't just die off eventually, things like that. And the hemangiomas have stem cells, that's been shown. They don't seem to be killed off by propranolol. So it's really the division of those stem cells into what are called daughter cells, the children of the stem cells, if you will. Those are very much affected by propranolol. But if you have a lot of stem cells around and you have a lot of growth factors, for example, this has been shown with growth hormone occasionally in children who have face syndrome or are lacking growth hormone. They're given growth hormone, their hemangiomas may grow because, again, it's a growth factor that just makes everything grow. So I think it's very plausible that that happens, but the extent to which it does, the magnitude of that, I'm not sure that I know. Mitchell, do you have any comment about that specifically?
Yeah, it's a really good question. I think that we definitely see it a lot, but we weren't able to answer the question in the 10 and up study, the long-term outcome study. We just didn't ask exactly when kind of rebound happened or when late growth tended to increase. But it's something that would be really interesting to look into.
Thank you both so much.
So Jennifer had posted a question in the chat. she was just asking about when rebound growth, for rebound growth, would you go back to hemangiol or would you seek different therapy as far as laser, for example?
I think a little bit of it depends on what type of rebound growth. So if it's superficial in the skin, I have had really great success with laser therapy. And I think the laser therapy maybe works a little different in that it's killing the cells instead of like, I think propranolol kind of stuns the cells and stops them from growing rather than being toxic to the cells. So if it's superficial, then the laser is a great idea. Unfortunately, the laser doesn't go very deep in the skin. So many times if it's less than, just a couple millimeters in the skin, the laser wouldn't be effective. There are other lasers, but then you start to get into more risk of scarring. So I think then we would switch to oral propranolol. And I still would say like that late, at least in my experience, late growth, like, beyond like around puberty, it can happen, but I think it's extraordinarily rare. So it's sort of this exception that us as researchers were interested in, but even in FACE patients, it's extraordinarily rare. So I don't want people to be thinking that, their hemangioma that's under control is going to grow back, because that's very, very, very unusual. And in most cases, I think it's kids that, just never really stopped growing very much and just, still had, just ongoing, up and down growth. I don't know, Ilona, if that's been your experience, but it's really unusual.
I don't know about rare, but I would say uncommon. I mean, I think the more we look for it and the more we're open to the fact that it happens, I think we see it more. But so I don't think rare to me is like I see something once every 5 years or something. So it's not super common. I wouldn't expect it will necessarily happen.
Dr. Garzon has her hand raised.
Hi, good morning, everyone. I was going to also say, I think it is relatively rare to see the growth, but the special situations, of course, are the situations where children have received growth hormone to manage short stature. So that requires, I think, a special consideration.
Thank you, Dr. Garzon. Okay. Thank you, Dr. Drolet. I think that was a lot of really good information. One thing I want to say also is I forgot to remind everyone, and I appreciate you all for holding any questions until after the presentation, because it allows me to be able to put like a nice recording on our YouTube channel for families. And if you've been on my meetings before, you know that I'm very cautious about making sure that information about your children or about yourself or medical information, we don't want to put that on YouTube. So if we can just get that really nice recording, it helps our other families who are not able to attend today. So I just wanted to remind everybody about that. And then again, after the presentation, please ask the questions. These doctors are here today. We don't always have this opportunity to have these wonderful experts in front of us. So please, let's give them a warm hug and ask all those questions. Okay, Dr. Mitchell Braun, Dr. Frieden, you're doing the 10 and up study.
Amazing. Okay, I'll share my screen. Okay, so good morning, everyone. My name is Mitchell. I am a dermatology resident at UCSF. I worked on this long-term outcome study for FACE syndrome. And it's amazing to say that it was published in this past year. So one of the newer studies to come out about FACE. And I just wanted to give an overall review on kind of what we studied. There will be certain parts that will be talked about more in depth by other people this morning. So I'll kind of go over those sections a little bit more quickly. So just an overview, we've talked about this a little bit already today, but PHACE syndrome, because it was established as a diagnosis in the kind of 1990s, we don't know much about long-term outcomes necessarily, just there hasn't been enough time to really put our brains together and observe what happens when people grow up. There have been smaller studies that have established some kind of long-term findings. And we've talked a little bit about some of this already. So headaches being one thing that people have noticed as kids grow up into childhood and then adolescence and then adulthood as well. And then progressive changes to blood vessels, some cavities, learning challenges, hearing loss, and vision changes too. So this was a big study. We worked with 16 different sites across the United States, Canada, and then we had a site in Spain as well. We wanted to look at people ages 10 and older to try to do some interviews with them and also look at their medical notes to try to piece together what PHACE looks like as people grow up throughout the teenage years and into adulthood. And many different investigators and researchers were involved. So we had 104 participants. The average age was 16 and a half years, but we did have a range from 10 up to 77 years old. And again, people were from these main countries. So we'll talk about a couple different aspects of PHACE today. We already touched on hemangiomas and using propranolol just now, and we were talking about a couple different things. So the long-term kind of changes to the skin we'll refer to as residua. 94% of participants in the study had these persistent skin changes, and about half underwent treatments, the majority of which had laser therapies. And then the late growth that we were just kind of talking about now, we define that in our study as growth of the hemangioma after the age of 3 years old. It happened at about 13%, and it kind of ranged in severity. So some color change, some deeper growth or volume. And again, we unfortunately didn't kind of track that over time. It was more of a yes or no. And I think future studies, especially the study that Dr. Frieden brought up about the hemangiomas that don't necessarily follow the expected course, will help us kind of understand that aspect a little bit better. So the next couple slides are going to be graphs like this. They will focus on the types of kind of changes that we saw in the skin that persisted. So color change was one of the most common in up to 70% of people. That is mainly red coloration of the skin where the hemangioma was in infancy. We asked individuals to kind of rate how differently they felt this change was to them and how much it impacted them. So the majority of the people who had that persistent color change rated it in this kind of green and blue color, which is only slightly different or moderately different kind of than the rest of their skin. And then texture changes were also commonly seen. Sometimes there can be a little kind of fatty kind of leftover changes. And so again, we asked the people how different this was compared to their skin, and the majority said slightly or moderately different. And then there can also be some kind of swelling or bulk left over as well. And again, the majority are saying that there's just very slight changes. And then overall big picture, we wanted to ask people how satisfied they were with the skin changes that were left over. And the majority were very satisfied or satisfied. And then the impact on self-confidence, we asked everyone how much it impacted them kind of over the course of their lives. There was no impact in a lot of people, and then slight impact in others. This obviously changed over time. So we had many reports that during kind of childhood or adolescent years that there was more of an impact, but then this changed over into the adult years. Those who had ulceration or surgical treatments in infancy did report bigger impacts on self-confidence. We think that this is likely due to the scarring that can be left behind for both ulceration and the need for surgery. So neurologic findings, findings related to the brain. So obviously we all know that FACE can have brain and kind of blood vessel changes. Headaches we've already talked about a little bit this morning. So 72% reported headaches with an average age of onset of about 70 years. So that is a bigger number, and also headaches tend to happen a little quicker or earlier in life compared to population norms. We also reported that about 45% self-reported learning differences, so challenges in school. 39% required some form of special education or IEP, which is an individualized education plan. But this really ranged in severity. So some people only needed a little bit of help with reading or math, and only 4 participants in the whole study of 104 had significant delays that kind of impacted their daily life. Posterior fossa abnormalities, which is the back part of the brain, and eye abnormalities were associated with the need for individualized education plans, as well as certain hemangioma locations. So primarily the one located in the center of the face. So diving into headaches quickly, we asked how frequently headaches occurred for certain individuals who had them. The majority was rare, less than 1 time per month, but there were, about 20% who had headaches often. So that's a greater than 1 time per week or daily or almost every day. And then length of headaches was kind of across the board. Some were quick and the others lasted for a little bit longer. And then headaches did have the potential to really impact people. So 20%, or sorry, about 10% said that it was very bothersome. And then 25% somewhat bothersome. I think this really just speaks to the importance of the multidisciplinary care for people who have FACE. Neurology team can be really, really helpful in tracking who needs medications and other therapies for migraines or headaches. And so progressive blood vessel changes, I won't go into too much detail about this because we have Dr. George here today who will talk about it in more depth. But we did see some blood vessel changes over time in about 30%. But again, it ranged in severity. And so we had a smaller number who had kind of higher risk changes that we saw. Again, Dr. George will chat through kind of this today. All right, and then we asked a lot of different questions to the participants who were all wonderful and provided amazing information. I think, this slide is a little bit busy. It crosses multiple different kind of domains of health. I think what's really exciting about this study is that it is one of the largest studies on long-term outcomes of FACE syndrome, and it provides a really good kind of foundation to look at next steps. So I think the survey of the FACE syndrome community was awesome because it helps to provide us a little bit of direction of where to go next. And so we have, information on vision changes in people older than 10, and we can go back and ask more questions. And so there's a lot coming in the future, and we'll kind of help to coordinate our future studies based on kind of your desires and your concerns. Fertility, we did have a couple of individuals who became pregnant and had full-term deliveries without complications. The offspring did not have FACE syndrome. And there were some degree of infertility in these individuals. They were ultimately able to become pregnant, and we didn't dive too deeply into this infertility and whether they needed certain treatments. And then the last section It's just quality of life. So we use some surveys to ask about people's overall health, anxiety, depression, the relationship with other people, and their ability to kind of participate in daily life. There were some forms that our individuals scored less compared to the population. So I was in global health, which basically is someone's report of their overall health and well-being. So these were slightly lower than population norms. We're not totally sure why this is or what is related to lower scores. And this did happen kind of during COVID. And so it was a little hard to parse out what exactly this is from, but it's something that is on our radar and something that we'll continue to study. And then this one down here in adults was ability to participate in kind of just normal daily life. And that was also a little bit lower. So overall, this is a great big study. It confirmed a lot of what we had seen in smaller studies, and also gives us future directions on where to go from here. It really does highlight, I think, the importance of multidisciplinary care going forward, whether that's for headaches for in neurology, learning differences, and the importance of kind of following up with primary care doctor to help with early intervention or other supports in adolescence. And obviously dermatology for residua if that is bothersome for individuals. And like I've said throughout the chat so far, we have a lot more to go, and it's exciting that we have kind of this baseline so we can continue to study and dive deeper. And then this slide, I just wanted to kind of highlight where to find some research on the PHACE syndrome community website. So there is this box up here labeled research when you just Google PHACE syndrome community. There's the published studies all here that you can click into and learn a little bit more. This study here is a review article that we wrote about 2 years ago now that is very comprehensive and something that you can provide to pediatrician, primary care doctor, kind of about what PHACE is and how it's changed and our understanding has changed over time. And then we also, in that study, provided just some recommendations on how to follow up over time for children as they age. And so it's something to, I think it's a great resource for you guys to be able to provide to healthcare professionals going forward. All right, so that was the long-term outcome study chat. Would love to answer some questions, and Dr. Frieden, feel free if you want to add anything else or any others as well.
That was great, Mitchell. And I want to say a couple things about the study. First of all, and the last comment about the paper that's in the Journal of Vascular Anomalies, which is a public access journal. So all of you can just Google it and find that article. There's a table in that article that basically says, you know, in preschool children, this is what we recommend for just routine extra healthcare maintenance beyond what any preschooler would get. And it goes by age. I think that could be super useful if you haven't already seen that table to have on hand, to just like the Milwaukee article, to have on hand, or this could be one that you could have on hand to give to your doctors or give them the link. I also want to say how proud I am of the work that Mitchell and our group did. And Mitchell started this as a, second year medical student, I think, maybe, Mitchell?
Yeah, I think it was third year.
Yeah, third year. And then took a research year. And those of you who participated and those people who did participate really gave Mitchell the opportunity to learn to be a researcher and to do amazing work as a medical student. He is now Dr. Braun, but he wasn't Dr. Braun when he started. and he's just done such a great job on this study. So we're very proud of him. So that's basically, we're happy to answer questions. And there are other people, of course, other faculty, doctors on this call who can also answer lots of questions.
Hi, this is Dawn. Sorry. Oh, I'm sorry. 1 second. I was just going to say that some people were asking about where to get that Milwaukee guide. It is available online, so you can read the FACE education book, and I believe, and also the lumbar education book by clicking a link at Children's Hospital Wisconsin. And we do hope to be making an updated version too. But I have several copies of the book that I could mail out to people, so you can email me or our group if you'd like a copy of the book. Sorry, I think someone was asking a question.
Yeah, thanks. One of the questions I had was, so our daughter, she's about 8 months old and has some of the arterial abnormalities in the brain, and just wanted to get a sense of, is there like correlations between the types of abnormalities or how extreme the deviations are, and what type of developmental delays are associated with that? I don't really just have any color around what kind of development delays mean or speech delays mean, and we're just not really exactly sure what to expect, other than it's a really wide range of outcomes.
Well, I know that Dr. George is going to be talking in more detail about radiologic abnormalities, particularly in the brain. The study, just to emphasize what two takeaways that I got from it, and Mitchell, feel free to chime in, were for that patients who might be more vulnerable, where you really want to, I think we should be paying close attention to developmental milestones in any baby that's born, make sure they sit up at the right time, roll over, language, things like that. And most of the outcomes are very good. Most children with FACE syndrome will not have severe developmental delays. I think that is a takeaway. Not severe, but maybe some. So there may be vulnerabilities to watch out for. I think if there are abnormalities of the posterior fossa, meaning they're not arterial, but brain abnormalities where the brain didn't form correctly, particularly the back of the brain, which is called the posterior fossa, or other parts of the brain, those seem to be somewhat higher risk in terms of having more issues with developmental delays than patients who just purely had arterial abnormalities. So that was an important takeaway, I think, from the study. At least for me it was. I don't know if Mitchell or Elizabeth, you want to chime in. Dr. George is a neuroradiologist, so we're happy to have her with us this morning.
Thank you. No, I agree with Ilona, and I know Dr. Vassar is on as well, who's a neurologist, a pediatric neurologist. But yeah, from our study, that was the take home. It's more the structural, actual brain abnormalities rather than the arterial abnormalities that was associated with issues with education and need for help later on in life.
Okay, that's helpful. Thanks. And
just from a sorry, just from a parent point of view, as somebody with an older parent, with an older child, our daughter had pretty substantial hypoplasia of the right side of her cerebellum, so some pretty big structural differences. And we had a radiologist tell us, she's not going to walk or talk or be able to take care of herself, and that was a decision that person made to share that with us. But just moving forward, she's 10 now and she does all of those things, especially the talking, so I think one of the biggest takeaways that I had from a neurologist conversation over the years was that this is a mystery of how the brain is so very flexible and things can change, and that to put limits on these kids is not something that is smart to do, because the brain can do amazing things. So I know that a lot of you are young, have young babies and are being told things, and just know that the data on that is hard to come by, because the brain just does incredible things all the time. And so to not be super, super concerned at a young age about the delays coming up, because they may or may not even come.
Yeah, I love that. I think that kids are very, very resilient, and we can't really predict, you know, that we see this and we're gonna get this. And so there's always room for just supporting kids as we see them grow up, and some kids will just need a little bit more support. And you know, we have these networks in our healthcare system where we can provide that. And so just I think relying on doctors throughout the way and the community too will be helpful. And it's hard to, again, predict exactly what's going to happen, but kids are wonderful, and we have a lot of resources that can help support people.
With regards to treatment, so my daughter's 20 now, and we've been following, well, actually, I know a lot of you guys from the beginning. My daughter has kind of, we're from very rural Iowa, so we do not get a lot of multidisciplinary. Thank goodness I'm a nurse, so it's been a lot of me coordinating care for her. Of course, we've accessed Cincinnati, we've accessed Milwaukee, which have been godsends to us. She's 20, she's kind of aged out on a lot of places. What we found is anyone still following them as they're going into adulthood to try to help? I won't lie, with that comprehensive, just overall making sure. I love this. I just looked up the article. That was awesome. Kind of, you know, for follow-ups and stuff that she should have. But a lot of it's been left back on our own again, to try to piece together, trying to re-educate doctors, trying to get neurologists to understand, you know, the fact that she can't be treated with triptans, you know, the fact that she has the migraines. Are any of you guys still following them? I know, like I said, we used to travel back and forth to Milwaukee. Are you guys still following them as they start to, what we're finding is we're aging out of a lot of our children's sections, you know, the cardiologist, now we have to find an adult cardiologist. Are any of you guys still following them comprehensively as they go into adulthood that would make it easier? Oh, there's Dr. Drolet. I think she just answered me. Okay.
Hi, this is Maria Garzon from Columbia University in New York. What you're pointing out is an issue that we're facing across vascular birthmarks. This is what we call a transition of care issue, that you're familiar with this because of your medical background. But on a larger level, there definitely are initiatives that are starting to educate the adult specialists in different areas so that they understand these conditions, whether it's neurologists or for other types of vascular anomalies, we need hematologists and oncologists. So we hear you, and I do think this is a priority.
Thank you. That's kind of what we're battling right now, is trying to just keep everything back together and as new things pop up. But I will say what Whitney said, 20 years ago, we were told a lot of different things with a lot of her issues. And to see her today, she's amazing. So yes, I would agree with what Whitney said, you know, listen to what your doctors are saying and stuff, but no, they come out pretty good. So you would be surprised at what they do and how resilient they really are.
Thank you. I think it's nice to have the parents of older children on this call for support for the younger ones, and just to know that, you know, to hear these stories and the success of your children. So I know it can be very scary when you're starting your FACE journey and you're not quite sure what to know or what to expect, or it can be really difficult. So thank you for speaking up to that as well. Are there any other questions? There were a lot of really good questions with this session as well.
Hi, good morning, everyone.
Hi, Priyanka.
Yeah, hi, Maureen, how are you?
Good.
Yeah, I just wanted to ask, like, what particular kind of the posterior fossa abnormalities are like related to any kind of developmental delay, like just like a hypoplastic cerebellum? like what should we keep on watch for the kids, like with the hypoplastic cerebellum?
Rachel, do you want to try and answer that question? I mean, I think it's going to vary from child to child. And what we found in the study was really a correlation. It's not a prediction. It's just that we saw a lot of patients, and this is just what we saw, what the numbers told us in terms of need for IEP, individual education plan, that kind of thing. But I'm not a neurologist myself, and I don't, Rachel Vassar or Elizabeth, I don't know if you, Rachel, maybe you want to chime in here.
Ilona, did you guys separate out migration abnormalities from posterior fossa? I think they were all kind of grouped together, right, Mitchell, in the structural brain.
Yeah, we did looked at like supratentorial versus posterior fossa, but that's it.
Okay.
Yeah.
Those are some big words too. So maybe Rachel can break that down in her answer.
Hi, everyone. I'm Dr. Vassar, and I'll be talking a little bit later, but just to give kind of a brief answer, I think these are all great questions, and it's the challenges that even within abnormalities of the posterior fossa, there's such variability. And so I think this just speaks to the importance of really getting a neurologist involved early on who can probably give more specific, specific predictions, albeit still hard to predict with any one kid, but I think give specific recommendations for your kid and what they would expect based on the very specific abnormalities. I think in general, cerebellum or posterior type of malformations, they would be more likely to affect speech development, but much less likely to affect like motor skill development. But again, like that's, kind of a generalization. So support having a neurologist on your team of many doctors.
Thank you.
Thank you so much. Okay, Dr. George, welcome. It's nice to meet you. I've not met you in person yet, but you are up talking about imaging.
Thank you. Let me figure out the share in a minute. All right. Thank you, everyone, and thanks for the invitation to be part of this meeting. And I'm happy to share the neuroimaging results of our 10 and older study. My name is Elizabeth George. I'm a neuroradiologist at UCSF, so probably not one of the specialists that you routinely see in your multidisciplinary care, but we're very much still involved in the care of you or your child. Just to briefly, we've talked a little bit about brain structural abnormalities, and we just talked about how there are different abnormalities and this were studied separately. So what does that look like? So as all of you know, imaging is an important part of the diagnosis of PHACE and is part of the diagnostic criteria for PHACE. So we as neuroradiologists work closely with your neurologists and your dermatologists to figure out what the brain abnormalities are, and also in certain cases suggest a diagnosis of PHACE based on the imaging findings. So these are both MRI images, and this is that back part of the brain that we've been talking about in the last few discussion points, where this side of the brain, back part of the brain, is smaller than the other side, and that's sort of the cerebellar hypoplasia that was mentioned, which can be associated with PHACE and is kind of is what the P stands for in PHACE, the posterior fossa malformation. And like Dr. Drolet was suggesting, there are also other abnormalities in the supratentorial brain, or not the back part, but the upper part of the brain, including abnormalities in the middle, we say the midline structures, and that can also be associated with PHACE. And as all of you are familiar with, arterial anomalies, that is abnormalities of the blood vessels of the head and the neck, are relatively common, or a very common finding in PHACE. And this is what some of that can look like. This is an example of a baby, actually just a few weeks old, where well, on this side, this is more of the normal side, and you can see on this side, this is the bright structure is a blood vessel, and it's very tortuous. So it takes a lot of loops, and that is a relatively common finding where blood vessels are very tortuous or loopy, which can be finding that can suggest a diagnosis of PHACE. So most of the imaging studies on PHACE have so far been cross-sectional or a single time point. So we did an MRI or a CTA in subjects with PHACE, and these were the abnormalities. But there's very little known as to how these change as the child grows. Some of these we do not expect to change. So things like posterior fossa malformation or some of these structural changes in the brain, like if a certain part did not form properly, we don't expect that to change over time. But other things like blood vessels, there have been studies that have shown that these blood vessel changes can change over time, but we do not know how frequently that occurs, when that occurs. So some of these questions is what we were trying to address as part of this study. So as Mitchell mentioned, this was a very large study of 104 participants from hospitals all over the world, but mostly the United States, who had PHACE and were over 10 years of age at the time of enrollment in the study. And this was a huge effort by Mitchell and others, including a lot of chart review and interview with the participants to have this comprehensive assessment of their PHACE symptoms, as well as their quality of life, among other factors that were studied. So what about imaging? So for this study, what we did is review the brain imaging reports at 2 time points. As you can imagine, these are about 16 sites all over the world, mostly the US, but still including international sites. So it was very challenging, as you can imagine, to get the actual imaging from all of these sites shared in a way that protects the patient's privacy and their health information. So that was challenging. So instead, we chose to have the imaging reports shared, from which it's relatively easy to remove the patient identifying information. So we had access only to the reports and not the actual imaging. And this was done at 2 time points, one when they were very young, around a year of age, and then the investigators provided us with an MRI report at that time. And a second time was for the latest they had, the latest imaging time point they had at the time of enrollment. And some of these were CTs, some of these are MRIs, whatever imaging they had of the head and neck was shared with us, the reports. So not all of the 104 participants had imaging, but among the ones that had imaging that we included an imaging component, the median age was around 14 years, and the time between the MRI reports were about 9 years. So that is sort of the median time of follow-up we had between the 2 study reports. So what did we find? So the posterior fossa malformations, or malformations of that abnormalities at the back of the brain, were seen in about 36% of patients, which is not unexpected. And one other imaging finding that is known but not studied well is hemangiomas in the brain. So just like hemangiomas in the face or the skin, some PHACE participants had hemangiomas in the brain, which was seen in about 30% of our participants. And that is similar to what has previously been reported, but this is one such finding that's not been studied very well. And we'll talk a little bit more about this later on in these slides as well. And so the finding we were most interested in, like I mentioned before, were these vessel abnormalities, because those were the ones that have a potential for change over time. And that was the main purpose of the study. How do these change over time? So at baseline, that at that 1 year time point, about 91% of our subjects had vessel abnormalities, which, as all of you know, is one of the more common imaging changes in PHACE, so that is not unexpected. And as was mentioned before, there was a broad range in the type of vessel abnormality and severity at baseline. So as some of you may know, there is a scoring system that has been suggested to kind of risk stratify these patients into low risk, intermediate, and high risk based on the vessel abnormalities. And we found all those, that wide range in severity. And this is some pictures. This was that patient that I already showed you with that tortuous vessel. And one other finding that we commonly see is when one vessel is smaller than the other or narrower than the other. So this bright structure on this side is a relatively normal vessel, and on this side you can see it's smaller or narrower. That is also among the range of changes that we see. So Mitchell briefly mentioned this as well, but the progression of vessel abnormality is what we were most interested in, and we saw that in about 29% of the participants in the study, and we were interested to know, is there anything that's associated with it? So this is, again, not like a robust prediction that everybody with a certain finding would have progression, but merely an association, like those who had these hemangiomas in the middle of the phase, or this S4 segment, were more likely to have progression of the vessel abnormality. And if they were underlying brain changes, both either the posterior fossa changes or structural changes in the top of the brain, those subjects were also more likely to have progression. Again, just an association, not 100% prediction by any means. And we noticed that the progression was not associated with beta blocker use, which was also reassuring. So the vast majority of our patients did not progress. So this was that baby that I showed you in the beginning who had this MR at 2 weeks of age. And this is the same child at 8 years, and the vessel looked remarkably similar without any progression of their vessel changes. So 29% might seem like a relatively large number, but we also then kind of try to figure out which of them are more significant or were potentially more significant. So based on the consensus of the authors, we defined something that we thought would be a moderate to severe progressive change. And this was seen in a much lower percent of 9%. And interestingly, all of these patients that had this moderate to severe progression had a moderate or high vascular risk score at that initial time point. So there are some features that might be able to tell us who may have a higher risk of progression. And I think the very reassuring thing was that strokes were seen in a minority of our patients. So it's only 3 out of the whole 104 participants who had a stroke at any time point. And it's also important to note that one of these patients was actually 64 years old by the time they had their stroke. So it's only 2 who had either as a child, as not as an adult, as a child. Only 2 of these participants had a stroke. And those 2 also had simultaneous aortic disease. So that is something Dr. Siegel noted in her study as well of patients who with PHACE, who had stroke, that aortic disease might be a risk factor when they have additional vascular abnormalities in the head and neck as well. And then last few things, we touched upon these hemangiomas in the brain, or intracranial hemangiomas. And we had some patients, not a large number, a small number of patients who had follow-up imaging where we could assess how these changed. And a vast majority, 89%, these significantly got smaller or disappeared by the time of follow-up. So this is a child at 12 weeks and the same child at 16 years. And this bright little round things here are the hemangiomas. And by the time they're 16 years old, they're completely gone. So these were some of the imaging findings from this study. And the PHACE paper, the 10-and-over paper that Mitchell shared, is already published. And we're working on a separate paper on the imaging analysis and sort of a detailed report of the imaging findings. And as I mentioned, this was a review of just the reports. Our hope is to do a multi-center study to actually review the serial imaging and not just the reports. And I think another challenge was that we just had 2 time points. So for the patients who had some change, we knew that there was a change, but we did not know when that change happened. It could have been at any time between those 2 studies. So we don't have a timing of progression. And so hopefully with that serial imaging, we can have more information as to when that progression is happening for that small minority of patients. And hopefully that'll help guide who all should get follow-up imaging and when those should be done. There are some recommendations that are already out there, but a lot of it is based on experience, and it'd be nice to have data to back all of that up. So that's what I had for the imaging results, and I want to thank you all and this community for participating in the study, which helped us get a lot of critical information on how the imaging changes over time in these children. Thank you. Happy to take any questions.
Thank you, Dr. George. That was great information. Does anyone have questions?
I've got just a question. In one of your charts, you showed how the vessels was really thick in one and then really thin in another. I think for our daughter, it's actually missing entirely, and I was wondering if you had any experience with that, and just kind of, you know, again, it's just hard to get information about sometimes the specifics here when you're an individual case. So I'm just curious if you have any experience with that situation and what some of the complications or concerns could be then.
Yeah, thank you for sharing that. Yeah, it is not uncommon to have, you know, it's on a spectrum. Sometimes it's big, sometimes it's small, sometimes it can be absent as well. But the risk depends a lot on, there's a lot of collateral supply or connections between vessels in the brain. It's actually a circle of vessels sort of in the middle of the brain where there's a lot of connections. So even when one vessel is like totally absent, like you were saying, there can still be blood coming from, blood coming from other vessels to supply that. So just from that information, it's hard to know what the risk you know, what that risk score your child would be in. We need to know the full picture of what the other vessels are doing. How are the other vessels supplying that territory, if that makes sense? So yes, it is not uncommon to have a vessel absent, but there is often or almost always other vessels supplying that territory, and sort of that big picture is important, and Rachel can talk more as well.
Wonderful, thank you. Okay, if we have no further questions for Dr. George, what we will do is move on to Dr. Siegel talking about the registry.
Great, okay. I'm trying to get my screens to work here.
Like all the multitasking, right?
Yeah, I know. I can't click one button when I'm on the other button.
I
Okay,
know.
are we good now?
Yeah, perfect. Thank you.
Okay, great. Okay, so we don't have a lot of time to talk about the registry today. So this is mostly just to tell you that we're out here if you have any questions to contact us. But briefly, I just wanted to touch on the registry. I know actually I see a lot of familiar faces or familiar names out there, so I'm excited to see you all here. And thank you to everybody who has already participated or has ongoing participation in the registry. But why participate in research? Participation in research and in the registry is what makes it possible for us to gain this knowledge and learn the information that you've been seeing getting presented so far this morning, and also ongoing throughout the day today. And you know, I think what's already come up today also is that what we really hope to do as a medical advisory board and as PHACE researchers and lumbar researchers is to create papers that can educate your doctors, especially those of you, you know, we've already heard some people aren't living near academic centers, and what can we do to get the word out and educate physicians who might not have experience with these conditions. So that's, you know, really the kind of reason, the core reason why we're doing a lot of this. And then also to develop better care guidelines so we can help you understand what to predict, what we need to watch out for, what we don't need to worry about. You know, we've heard so many wonderful stories today too about just It's so great to hear the stories from adults and people doing so great out there. And then this is just, I put a plug here also for the Facing FACE 25 Years Later paper that we talked about before, just so you could see it there, and the link is on this slide too. Okay, so what happens if you enroll in the registry? If you're interested in learning more about the registry, we have a contact us page. There's a QR code at the end of this talk, or an email address. So you can reach out to us either way. And then we'll set up a phone call with our research coordinators and myself to talk to you more and find out if the study would be a good fit for you. And if so, we can email consent forms that you can do online. And then we've now streamlined it so that once you sign the consent form, it goes automatically to our kind of medical history form, where you can tell us a little bit more about what's been going on. And then you can upload these reports of like the brain imaging and those different things. And then if you're interested in joining our genetic studies, that's optional. You can either just do the clinical part, or you can do clinical and genetic. And if you're interested in the genetics, then we'll do a saliva sample and possibly arrange to have a blood sample done. So what are some of the questions we're working on right now? You've heard a little bit about how we're trying to understand which brain imaging features are at higher risk of complications. And I saw Whitney put in the chat that, the possible risk of stroke is one thing that families really worry about. And, luckily what we've been seeing in all of our research so far and in these studies is that it's so extremely rare. So that's really reassuring. But we still want to understand which are the people who we need to follow more closely, and then who also might be at risk for other things like seizures or transient ischemic attacks. And how can these brain imaging, the MRIs that get done, how often do we need to do those, and which features need to be followed up more closely? And we have a set of guidelines that we created, but with the hemangioma investigator group, but we want to make sure those guidelines are right, and do we need to make any adjustments to those? So that's part of what this ongoing research is. And then we also have a small amount of funding from the Pediatric Dermatology Research Alliance to look at whether it's possible that some immune factors, maybe complications happen with infections or with other triggers with the immune system. So we're trying to look into that with saliva samples as well. And then, so the big question we've already heard about today, what is the cause of FACE? Well, unfortunately, we're still not sure. It's been difficult to figure it out, but we have several different ideas that we're looking into with our research. And there's a lot of big words on this slide, but there's all different kinds of ways the genes could contribute to a condition happening. It might be that there's a whole bunch of different genes that act together that cause it. It could be that some structural changes in the DNA called copy number variants might play a role. It might be that there's a gene change in just some cells in the body, like in some of the blood vessel cells or some of the skin cells that result in the hemangioma or the aorta cells. And so we're trying to look at that. That's a little harder because for that we need a little piece of the tissue to study it. But we are, as we can, we are collecting those and examining those. It could be something, during development, something with the genes interacting with the environment during pregnancy or during development. And we have done some prenatal studies in the past and have some that we're continuing. And then to try to understand how the genes might be working, we're currently doing some studies where when we can take blood samples and then we can actually grow like little mini hearts called cardiac organoids. And so we could look at the function of different genes that might be contributing to the blood vessel changes or the heart changes in FACE. And so this is a slide that shows about our contact information. We have our phone number, our email address, and then this QR code will take you to the contact us link where you could fill out a form to get in touch with us. And I just also wanted to mention, in a small group of people, we have the opportunity to work with the Gregor site at Stanford, and they have really sophisticated sequencing that they're able to do to look in all new ways that we might not have looked yet to see what changes might be causing face and lumbar. And so that involves a blood sample, and that team, if you were interested in participating in that, you would enroll in the FACE registry, and then we would refer you to the Gregor site, and then they would arrange the blood draw, and you get a gift card. And mostly those are like more people who have like multiple PHACE history. They were also interested in if the mom had multiple miscarriages, that might be something that was where their testing might be helpful. And then if there's any other kind of more like a combination of FACE plus another syndrome or genetic condition, that might be another family that would qualify. So thank you to all the families for participating in the registry. We definitely, couldn't gain all this knowledge without you. So we're so grateful. And here's again our contact information. So that's it. Thank you.
Thank you, Dr. Siegel. I also posted the link to the on from our website into the chat. And again, the follow-up materials I'll be sending out will include some of these, most of these links, or all these links that we talked about today, just so that if you can't grab them from the chat, you'll have them in the email as well. So thank you so much. Okay, do we have any questions about registry? Aaron Perry, you have your hand raised.
Oh, sorry.
Go ahead.
So my question is, like, if we signed up for the registry a while ago and filled out the paperwork with some of the like health history information that affects our child, but then additional diagnosis came about or something, how do you want to be updated on that? Or how is that update go? Or like, I don't even know if maybe we signed something to give you access to all his medical records and you can pull that out of Epic. What does that process look like, or what would you like us to do? Because I know over the last year, Connor had a couple of additional kind of diagnoses.
Oh, yeah. Yeah, please, if there's new updates, please reach out to us and let us know. Because we won't automatically get anything. So we would need you to inform us and send us that information. If in some cases, you do have the opportunity to create a Stanford medical record number. And if you decide to do that, then we could get the reports ourselves through your research medical account. But that doesn't happen automatically. So we would definitely need to set that up, and then you would need to tell us to go looking for something. And then we are hoping, it's been a goal for a long time, but with my move, it got delayed a little. We are hoping eventually I'm hoping 2025, we'll start launching our annual survey. So kind of just, so that we can find out all the new things or any changes that happened over the prior year. So hopefully that's going to kick off January 2025. But in the meantime, please send us any updates.
Okay, thank you.
Okay, Whitney, you have your hand raised.
Yeah, just in reference to the study that you mentioned at the end, the additional genetic conditions, does that include like autism and those in that realm?
Yes, I think it could. Mm-hmm. What would happen is that we would connect families with Gregor, and so then there would be like an intake process with Gregor just to make sure. So I don't want to promise, but with that one, if we also there is the possibility that if you have a referring like neurologist or geneticist, we can add their name, and with the Gregor, they might be able to, if there's like clinical actionable results that come in, then they could share that with your treating physician as well.
Perfect. Thank you, Dawn.
Thank you so much. Okay, thank you. Again, if anyone has any other follow-up questions, please send them to me and we can pass them along, to the doctors as well. So don't feel like if you didn't ask the question today, you're not going to get the answer. I know that sometimes it takes a lot. You have to take a lot in and there's a lot to absorb. Awesome. Okay, Dr. Metry, you are up with lumbar.
All right, can you see my screen okay?
Yeah.
All right. Well, good morning, everybody. I'm Denise Metry. I'm a pediatric dermatologist in Houston, and I have also been involved in the FACE syndrome community since the very beginning, and it's been my pleasure to watch it just grow and help so many families today. So I'm going to talk about lumbar syndrome. And historically, lumbar hasn't been talked much about in the FACE syndrome community because we haven't known much about it, but it's part of the FACE syndrome community family. So these are FACE and lumbar are really sister syndromes. FACE affects the upper part of the body and lumbar the lower. And because of that, I think learning about lumbar or FACE will help teach us about the others. So even if you're on this call and your child has FACE syndrome or you have FACE syndrome, it's still really important to learn about lumbar too, and vice versa. So I'm excited to share with you all what we have learned in the last couple of years. So what I'm going to cover today is what the lumbar acronym stands for, what a lumbar hemangioma looks like, which is very similar to FACE, how to diagnose someone who's at risk for this syndrome, who gets it, or at least what we know so far, and what we think could be why, how to take care of a child with lumbar, and then finish with resources and ways you can help. So I'm going to go into each of these findings in a little bit more detail, but what lumbar stands for is the L is a lower body hemangioma. This picture here is pretty typical. It's often extensive, like in FACE syndrome, but sometimes it can be small. The U stands for problems with the way the urinary system developed or the genitalia developed. And the hemangioma in lumbar is particularly prone to ulceration, so I'll talk about that. The M stands for spinal cord malformations. We've changed this. The original lumbar acronym, the M stood for myelopathy, but that's actually a symptom. That's not actually a birth anomaly, so we've changed it to spinal cord malformations. That's the most common, other than the hemangioma, the most common finding we see in lumbar. B stands for bony changes within the same lower body area as the hemangioma. A stands for problems with the way the anus or the rectum developed, or arterial anomalies, just like we see in FACE syndrome. And the R stands for renal, also known as kidney problems. And just like in FACE syndrome, all of these findings are present at birth. And just like in FACE syndrome, most children do not have everything in this acronym. They typically have the hemangioma and just one or two other findings. So here's what a lumbar hemangioma looks like. So just like in FACE syndrome, it's segmental. So it's not round, it's pattern and tends to kind of cover an area in a pattern. It's usually large and extensive, so often patients with lumbar will have a hemangioma that covers the lower back, the buttocks, and even sometimes extends all the way over a leg or even both legs. But sometimes too, it can be small, like this one here. So it doesn't have to be very large. And it's often a special type of hemangioma. You may have heard this term before. It's called IH-MAG. And the IH is for infantile hemangioma. The MAG is for minimal or arrested growth. And that's when hopefully y'all can see my arrow here. That's when the hemangioma stays really flat in most places and just doesn't grow, like raise up above the skin very much, except for sometimes you'll see a little bit of hemangioma growth at the edges, like here, or a few small, like tiny red bumps in the middle. And so for that reason, sometimes it can be confused, just like in face syndrome, you may have had a child who, first there was concern your baby might have had Sturge-Weber, you might have had that. Same can be true in lumbar syndrome. It can be mistaken as a port wine birthmark or even as a diaper rash at first. And as I mentioned, even more than face syndrome, a lumbar hemangioma can be very prone to ulceration. And sometimes that ulceration can be really severe and difficult to manage. So I'm going to talk about that. Okay, so the most common finding that we see other than the hemangioma is problems with the way the spinal cord developed underneath the hemangioma. And the most common type of spinal cord malformation that is seen is something called a tethered cord. And that means, if you've heard that term, that there is a connection between the skin, the hemangioma, and the spinal cord. So normally your spinal cord is free to move up and down. So when you or your child, you're running, you're jumping, it has the ability to move. If it's tethered, if it's connected to the skin, it can't do that, right? It's not flexible. So with running, with jumping, with movement, it can tear, and that can lead to damage of the spinal cord. Sometimes, as I mentioned, about a third of children with lumbar will have problems with the way the urinary tract developed or problems with the way their genitalia developed. So in this little boy here, you can see where the scrotum is what's called bifid. That means it's separated into two different parts. And then this little girl over here has what we call ambiguous genitalia. It's really difficult to tell her gender, right? So this is, in my mind, one of the most difficult things a child with lumbar. I mean, you can imagine as they get older, they're entering puberty, adulthood, how devastating having these types of changes can be. Sometimes the anus or the rectum didn't develop properly, or it's blocked. And so sometimes you'll see abnormal connections between your intestines or your urinary tract and the skin, and that can be surgically repaired. And sometimes we see kidney problems. So either one kidney is missing, it's in an area of the body where it shouldn't be, or sometimes the kidneys are even fused together. And this is what's called in this picture a horseshoe kidney. There can be changes in the bones. So same again, all these findings we see in the same area, like this lower back, pelvic, buttock, leg region. And sometimes in those areas, the sacrum or the coccyx, which is the very end of your tailbone, does not develop properly or can be missing even. And then just like in face syndrome, we see the same types of arterial anomalies, either in the pelvis or more commonly the limb. And it's not actually very commonly reported in lumbar, but we think that they are common. It's just that they haven't been evaluated for. We had the same issue in the beginning with face syndrome. So we feel like they're there, they just haven't been looked for. But those arteries, just like face, can be missing, small, too narrow, all the types of things we see in face. And we really don't know what that means long term. We don't have any information at all on older people, young adults with lumbar syndrome. So we don't actually know what this might mean for a child who's affected. And then other skin findings, sometimes we'll see, for example, like here, like a dimple or a sinus tract. This can also be a connection with the spinal cord that can cause a tethered cord. Sometimes we'll see areas of extra skin, like these tags like here, or what's called a pseudo tail, or skin tags like here. And we've just, Dr. Siegel and Dr. Drolet and I have done some work on this, looking at these aren't actually, they're not extra skin. They're actually unusual skin findings that have skeletal muscle tissue within them. And we see this in both face and lumbar. And so we're trying to figure out what that means about possible cause when it comes to face and lumbar. Okay, so a lumbar hemangioma may affect any of the following regions. So it can be lumbosacral. So that's above, so the butt, I'm just going to say butt crack. I know that's not the medical term. It's gluteal cleft, but nobody knows what gluteal cleft means. So I was going to say, like, so the hemangioma can be above the butt crack up here. It can be within the crack, like down here, or it can be between the anus and the genitals or involve the genitals. So a lumbar hemangioma can affect any of these locations. And sometimes it also extends down a limb. So how do we diagnose a person at risk? So especially when the hemangioma involves the lower back or that butt crack or around the anus, we want to make sure we image the spine to make sure that there's not a tethered cord or another spine problem with the spine present. Usually that's done with an MRI exam. Occasionally it can be done with an ultrasound in a very young infant who's at lower risk, but most of the time an MRI is needed. To evaluate the kidneys and the urogenital system, everything in the pelvic area, we can do an ultrasound for that. That does not require sedation. And then if the leg is involved, we do recommend that the leg also be ultrasounded. We can also do what's called a Doppler ultrasound that assesses blood flow within the limb, and that can be helpful for trying to figure out if there are blood vessel anomalies or problems within the leg. So this was just published 2 months ago, where we established diagnostic criteria for lumbar syndrome. And this is a big deal because this is the first time we've had diagnostic criteria for lumbar. We established them for face, in 2009. We updated those in 2016. Dr. Garzon and Drolet, everybody on this call was really involved in that. But we have not had diagnostic criteria for lumbar until now. And this is a really important thing because in order to study a rare syndrome most effectively, you need to have a really well-defined patient population to do that. So this is a really important starting point for us to do further research in lumbar and try to answer questions for families. So this is also open access. So you can Google it on this link. Maureen's also going to be putting this link under where Mitchell shows you under the FACE Syndrome Community website, and there's research there. She's also going to post the paper there for your access. So we're really excited about this. This is a project that involved lots of different doctors, lots of different specialists in pediatrics, ranging from pediatric neurologists to pediatric orthopedic surgeons to all kinds of people, and actually involved physicians from all over the world. So this is a really, like I said, really important step that we're excited about. So here are the criteria. You can see they're pretty simple. So all you need is a segmental or patterned hemangioma involving any of those regions, the top of the butt crack, within the butt crack, or anywhere in the genitalia area, and one other finding on this list. So if you compare the diagnostic criteria for lumbar to those for face, it's much simpler. There are no minor criteria in lumbar syndrome. There's no diagnosis of possible lumbar. You either have the syndrome or you do not. And we did not set a minimum hemangioma size. It just has to be segmental patterning. And that's because we really couldn't come up with a smallest size. We feel like it's probably somewhere around 2.5 centimeters, but we don't know that for sure without doing prospective studies. So we feel like, just like the FACE syndrome diagnostic criteria, we're going to be modifying these over time as we learn more. But this is a really really good place to start. Dr. Siegel and I have also been looking at risk factors, like which babies get lumbar, looked at their moms. And so far for lumbar, we have just done this retrospectively, like looking back. So in order to develop the lumbar diagnostic criteria, we did that using data that we had from 140 people who'd been published with lumbar. We put that all together and we that's what we studied. And this information is from that same group, those 140 people. So what we really need is to do this. We need to look at risk factors prospectively. And Dr. Siegel has a medical student who's, I believe, is on this call, Bianca, who's going to be taking a deeper dive into risk factors. But from what we at least know retrospectively, and this has not been published yet, the manuscript's been submitted, but you can see that babies who get lumbar are very similar to babies who are at risk for FACE syndrome. It's more common in females, but not as common in females as FACE. So a significantly higher number of boys have lumbar compared to FACE syndrome. Dr. Siegel and I and others have also looked at, well, are girls with FACE or lumbar, or are boys with FACE and lumbar more severely affected than the opposite gender? And so far, that does not seem to be the case. Boys and girls seem to be equally affected. Lumbar, just like in FACE, tends to happen in babies who are normal birth weight and term. They're not premature, which is odd because for hemangiomas in general, hemangiomas are much more common in small preterm babies, but that's not true in FACE and lumbar syndromes. Just like in FACE, we have no family reports in lumbar, no evidence of that. Lumbar has not been reported in a twin birth either. FACE has rarely, but lumbar has not. Maternal age, mothers with lumbar seem to be a little bit older, but it's not significant. We have thus far, we can't identify any other risk factors in parents retrospectively, and no genetic studies have been done on lumbar. So I'll talk about, I'm just going to put in another plug for Dr. Siegel's registry when I finish, but this is super, super important. The other interesting thing, and Dr. Garzon and other colleagues of ours reported on this pretty recently, of babies who have both FACE and lumbar. And so this is an example of a baby who's got Anne mentioned like the S of FACE, face ease can mean sternal cleft where the skin didn't come together, overlying the sternum. And you can see that here, and then a smaller hemangioma here of the ear. But then this baby also has a really large IH-MEG minimal growth hemangioma of the limb. So there are children who have this overlap. And what does that mean? We also know that lumbar not only overlaps with FACE syndrome, but another syndrome called OEIS. And this is really similar to lumbar, except it's much, much more severe. So this is one of my little babies who has, again, a minimal growth hemangioma of the leg. And omphalocele and exstrophy means that the skin didn't come together over the stomach and the pelvis. And so you don't have any protection of the organs underneath. And I'm not going to show you pictures of that because it's a really severe birth defect, but I will show you that. So this is a baby with FACE syndrome, and this is, again, the S can stand for sternal problems or the supraumbilical raphe, this scar that extends upward from the belly button. And you can also see this rarely in lumbar syndrome where you see a skin defect below the belly button. And when that opens, so you can imagine that baby I showed you with the sternal, with the skin missing from the middle of the sternum, that can also happen in OEIS, where the skin didn't come together in this location, and then you have exposure of the organs underneath. So This is another syndrome, we're looking at because again, learning about one can teach us about the other. So we've had several babies who have this overlap of this OEIS and lumbar, and we just published this as well, and trying to figure out what that means. So this is that paper. So if you put like lumbar and face and OEIS and you look at like a timeline, so this is, the time from barely like right at the beginning of conception to 3 months in utero. When do all these things happen? And they seem to happen very early, like 3 to 4 weeks into embryogenesis. So very, very early on. And then just like Dr. Siegel was mentioning, we don't know why this overlap is occurring, and we don't know the cause of any of these. There's actually, for many birth defects out there, the cause is not known. And it's probably a combination of factors like Dr. Siegel has mentioned. But that's where we're going with trying to figure it out. So taking care of a child with lumbar requires a multidisciplinary approach. And that means, of course, depending on which findings a child has, they might need several different pediatric specialists. So the pediatric dermatologist or another specialist in vascular birthmarks can help with the hemangioma. So just like in face syndrome, the hemangioma can be large, it can be extensive, and I mentioned it can really be prone to ulceration. So sometimes babies with lumbar, just like in face, require wound care for ulceration, require pain control for that, and also typically or often go on oral propranolol, and often are on propranolol for quite a while sometimes, especially to control ulceration. The other thing that can happen, just like in face syndrome and lumbar, and Mitchell mentioned this as well, is that the hemangioma leaves behind residual changes. So here's just some examples of that on the leg, where you see kind of these extra veins left behind, or in this child over here, you see still, like Dr. Frieden mentioned, this like red hemangiomatous type tissue or scarring, from ulceration. And some of this can be treated really effectively with laser therapy. And this is not a child with face or lumbar, but just to show you some of the changes that can be left behind. And just an example of having some of the laser techniques we can use. For this child, I used several different lasers for her. One to help treat the red, one to help treat bigger veins, one to help with scarring. So all of the things for the face and the face syndrome can also be used for lumbar as well. And then, of course, beyond just dermatology, neurology and neurosurgery are often very involved in children with lumbar, since the tethered cord is the most common finding we see. So they will often be able to release that tethered cord. Our urologists, our kidney doctors, our pediatric surgeons can help, for different findings of surgical corrections needed. I will say that in children with lumbar, it's also often best to wait until that hemangioma has been really effectively treated with propranolol before doing surgery, because sometimes if you do surgery and the hemangioma is still active, healing can be difficult. So typically that's another reason propranolol is really important. And orthopedics, so our bony doctors can help sometimes. If a child with lumbar has a leg that's affected with the hemangioma, there may be a difference in the size of that leg. It may be smaller than the other, for example, and they can help with mobility issues for children affected. So ways to help. So some of you may know there is a lumbar Facebook group that I believe has been fairly active in the past. And just another, as I mentioned, I wanted to put a plug in for the FACE registry, which is also the lumbar registry. and Dr. Siegel and Bianca have helped develop lumbar specific questions for the registry. And I believe, Maureen, you can correct me on this if I'm wrong, but from the survey, I believe that there were 16 adult individuals with lumbar syndrome. And for you all, since I mentioned before, we don't know anything about what happens to children with lumbar as they get older. So we don't have the ability to help educate families with younger children with lumbar like we now do from the 10 and up study with PHACE. We don't have any of that information for lumbar. So that's where that type of information is it would be so important for us to have that and be able to understand the syndrome better. And then, as I also mentioned, not to my knowledge, not a single child with lumbar or an adult has been genetically tested the way Dawn is doing with her genetic testing. So if that's something you're interested in, that would be really, really helpful to move things forward and learn more as well. So I think that is all that I have. Again, lumbar hasn't been talked about a lot, but again, sister syndromes, and we're really hoping learning about one helps us with the other. So thank you for listening to me, and happy to answer any questions you might have.
That's great, Dr. Metry. I appreciate you coming in and us talking more about lumbar, because we're not going to be able to engage more families if they don't have the information that they need. So I'm just excited that you're here and that we can start getting the information out for individuals and then start learning more. Are there any questions for Dr. Metry? I'm not sure. I didn't check, to be honest, how many if we have any lumbar families on the call, but I will make sure that this gets posted into the Facebook group, and that we can encourage those individuals to be involved with the registry. I mean, that's how the learning happens.
Is there any way that us as community members can help, talking maybe to our doctors, bringing it up, anything like that, that might help get the word out or get more people to come to the group and learn more?
Well, I think we're trying, so we're, I think, working on making the PSC site have more information on lumbar. So hopefully that, people Google search and stuff like that, it'll come up. It's relatively rare, Whitney, compare even more rare than PHACE. So it's hard to know how many families are out there, but yes, any ideas to spread the word, everyone in the hemangioma investigator group who's on the medical board here for the PSC, we educate and advertise as much as we possibly can. We just presented this information at our, so actually the lumbar diagnostic criteria we presented at the meeting that Dr. Drolet just mentioned. We had our Society for Pediatric Dermatology meeting in Toronto last weekend. It's been presented in Madrid, Spain at the big International Vascular Birthmark Society. It's been presented at research conferences. So we're really, really trying to get the word out. But and I think Maureen's also been trying to connect with the Facebook group as well. Yeah. So that would also be really key.
Mm-hmm. Yep. Wonderful. Thank you so much.
Thank you.
All right, folks. So we are behind schedule, of course, because we had such a robust discussion early on. So just hang on. We have some really good sessions still. We're halfway there. So I appreciate everyone's time today again and the questions that are asked. So we are going to move on to Alyssa Ponce. Alyssa, am I saying that right? I met you in California. Child life specialist, and it's really great to have an opportunity for families to understand how to prepare children for whether it's appointments or medical procedures.
Yes.
So
yeah, and it's okay. My name is like so hard to pronounce. It's Ponce, but it's okay.
Ponce.
Yeah.
I know.
But But hello, everybody. I feel like for my presentation, I'm gonna pull it up. Let's see if I can share my screen. Oh, yep, here we go. But I would love to do more of kind of like a talking with families about different experiences. We're gonna go over, or I'm gonna talk about the, let's see, if it lets me pull this up. It's been a while since I've presented on Zoom, so give me some grace, please. But I'm going to talk mainly about like just hearing other speakers earlier today. It's like we're going to highlight MRI, like how are we going to like prepare and support our child through MRIs, through lab draws, and of course through laser procedures. Let's see. Sorry, my computer's a little slow. All right, this is kind of like a little bit overview of what we're going to be doing today. And so, hello everybody. My name is Alyssa Ponce. I am a certified child life specialist. I work really closely with Dr. Siegel on the pediatric dermatology outpatient team at Stanford Children's Health. Just hearing our recent speaker, very interesting to learn about that as a professional as well, because I work very closely with our outpatient neurosurgery team and I do a lot of tethered cord preparations too. So that's something that I will definitely keep in mind as I am working with those families as well to see if there's any connections and help advocate for that too. And so, what is a child life specialist? Just kind of feel free to unmute at this point. Like, have any of you worked with a child life specialist at all during your time?
Yes, lots of times, and we love you.
Amazing. And I saw Erin raised her hand. That's amazing. So as for those who don't know what a child life specialist is, so we are members of the medical team, the interdisciplinary team, and we work alongside them to help educate patients in developmentally appropriate ways. We are clinical professionals. A little bit about my background is I completed a 600-hour internship. I hold my master's degree in child life, and we help just advocate for our patients, help provide support through the fancy term of developmentally appropriate interventions is we work with 0 to 21-year-olds. And so basically what I would do for an intervention for an infant would not be the same thing as what I would do for like an 18-year-old that's going in for surgery. So just kind of helping families also understand like how to continuously, especially for our chronic patients, how to help support their development and also their understanding of their diagnosis and the procedures that they're going to do. So we'll kind of go into that a little bit. And then this is just like a little bit of a research slide that talks about the preoperative anxiety that some patients feel, that a lot of them experience a significant amount of anxiety. And I know that in the child life world, we're doing a lot more research to help enhance our field and show that our non-pharmaceutical interventions such as like comfort positioning and just advocacy for patients during that don't involve a lot of medications help also reduce those anxieties as well and help promote positive coping throughout their admissions and through their procedures. And also, one of the big things in research that is already kind of out there is that family-centered care really helps patients feel a little bit better, because when we're helping you guys as parents, I always say that our parents are one of the most valuable members of our interdisciplinary team, because we as medical professionals are only coming into a small part of your journey, and we get to, I feel like it's an honor to be able to walk alongside each of you to help you navigate the procedures and the medical environment and advocate for you guys. But when parents are feeling super anxious, there is a correlation to like a
child feeling anxious. And so when we're also supporting patients, we're also supporting you as well, and any siblings that are kind of navigating this too. And so here are a couple of things that the importance of procedure preparation. So what this would be, and depending on the different interventions, it could either be a mixture of like a verbal, psychological preparation. What that means is just kind of like talking through the steps of what we're going to be doing today, talking to the patient about what do you understand? One of my favorite questions to ask kiddos when I walk in is like, why are you here today? Why are you hanging out with us? Like, what do you know? Or if a patient's really young or they don't understand, then I'll be like, should we tap in mom and dad or like caregiver kind of to see like, what do they know? Like what have we talked about at home prior to this? And the main goal for that preparation is to help educate not only the patient, but also their families about what we're going to do, and it is shown to help reduce like that preoperative anxiety, because sometimes, especially for like our school age or teenage kiddos, even some toddlers, not knowing what's going to happen when you're going into a procedure that you've never done before can actually like cause more anxiety than actually doing it itself, because it's scary to do something you've never done before. Another part of my role is to provide that procedure support. And so that's when we're doing the preparation, I'm typically talking with families about, okay, what's going to be our coping plan? Let's kind of create one. Like, are we going to do distraction? Are we going to sit with mom? Or are we going to sit with dad? Are we going to sit with the caregiver? Are we going to bring our favorite stuffed animal or our favorite blanket? Are we going to utilize one voice? And for those who don't know what one voice is having in the middle of a medical procedure, having one person kind of lead the like child or the patient through the procedure. And so it doesn't always have to be a child life specialist. It typically is, but it doesn't always have to be a child life specialist. It can be either a parent or a guardian or even like a medical professional that's like kind of walking through. That way it really minimizes the amount of people that are talking in the room, because one of the most vulnerable things for a child going through a procedure, especially if they're laying flat on their back, is just to hear like so many different sounds as it's happening. Like we're hearing the machine of the laser, we're hearing maybe Cocomelon on the iPad, we're hearing mom's voice, we're hearing dad's voice, and it can just, or like, the medical team kind of talking, and that can just be really overwhelming for a patient. So always trying to advocate for one voice whenever I possibly can. Like a non kind of part of, what was it, for preparation, as far as like non, talking it through verbally, is what we like to call medical play. And so medical play is not only just for like after the procedure for patients to have that self-expression afterwards. I'm not sure if the FACE community does a lot of Dupixent injections, but that's also another huge part of what we do in the peds derm clinic as well. And it, like, having patients even after that injection kind of tell us like, okay, like what can we do to make this a little bit better for next time? I think that also is very relevant to also ask after a laser procedure or an MRI or any procedure in general, just to ask a patient simply, or even ask a parent or guardian, like, what can we do to make this a little bit easier next time? Or just even if your medical team doesn't ask that question, kind of be like, well, can you guys do this and this next time? Because another big part of my role is to help empower patients and their families to help advocate for themselves too, and know that it's okay to advocate for their needs. Remember that you guys are a huge part of the medical team, and that your child and your child knows themselves, especially if they're at an age that they're a little bit older and can express their feelings, like empowering them to also use their voice to help advocate for themselves. But kind of going a little bit, segueing back to medical play, is utilizing, it's mainly known as like playing doctor kind of, but just facilitating a space with either toy medical stuff or like also real medical supplies, and allowing them to kind of manipulate it either on themselves or on like your arm or like on a stuffed teddy bear or a stuffed animal. It kind of helps them promote that self-expression and understanding of what's going to happen, even if they're not using their words. And then as far as MRIs go, something that's really helpful for some patients, of course, one of the biggest assessment questions for me is, do you want to know what you're about to walk into, or do you not want to know what you're about to walk into? Like, if some patients say, like, I don't really want to know a lot of things, I'll be like, okay, I respect that. There's just a couple of things I want you to know. Like for an MRI, I always explain it as a big camera, or some of my colleagues say like a big donut camera that's really, really loud. That kind of sounds like some construction noises sometimes. A part of our preparation for MRIs here is offering the option to patients to hear what the MRI will sound like. So even if you don't have a child life specialist alongside you in your journey, you can always like ask your child, like, hey, do you want to hear what an MRI sounds like? And you can like pull up YouTube and just I think last year at the conference that I spoke through PHACE, like we had parents. It was so beautiful just to kind of like have the interventions kind of flowing and be like, oh yeah, we use this or that. And so I highly encourage that as well. And another big thing that's important to note for an MRI that some patients have questions about are like, okay, this is a big camera, it makes a lot of sounds. Why do I have to change my clothes? Because like I just want to stay in my comfy like sweats. Depending on like how strict your MRI technicians are at your hospitals, something I always encourage families for the patients to know is that it's a big, large magnet. So we want to make sure that your body is safe when we're going into this big camera, because we don't want anything like metal on our body, and so we have to do our MRI safe PJs or clothing. Any questions about MRI or any experiences that you've had?
I'm curious about like the sedation part of it, since a lot of our kids have to get MRIs when they're very young.
Yeah, it depends on each hospital. I know for at Stanford, I guess it also depends on what kind of MRI it is. But they do like a mask induction. So for that aspect of MRI, as child life specialists here, we will help the families like pick a favorite scent. So our kiddos can, with the anesthesia mask itself, like they can put favorite stickers on it, to help normalize the mask when they're going under for general anesthesia. We do have a sedation team here at Stanford as well, so where we can do like moderate, mild, and like full sedation. So that's really helpful for some families, especially if there's an IV involved. And so helping navigate and working with your medical team to see what options that you have and kind of navigate that before scheduling the appointment. Each hospital is so different in what they offer, but I know I can only speak to like LPCH or Stanford, but encourage families to like inquire like, hey, like what are my options for this? Are we able to stay at the bedside until my child falls asleep with the mask? Or if they have to do an IV, like can I stay at the bedside with them and help them cope through that? And also, how can we best support them while also like not, I feel like some parents are scared to ask those questions, but like please always ask those questions. Does that kind of answer a little bit?
We had like the scent, that she picked, the mask itself and putting it over the face, I think can be really scary for toddlers. So is that, like a case for like medical play beforehand? Just
Totally.
other sort of strategies with the mask, I think.
Yes. Yes, totally. I think that's very common for that age group. They're kind of like, okay, this, like, even though we like picked our favorite scent, when it kind of gets down to it, they're laying down on their back and they're like, oh my gosh, okay, the anesthesiologist is coming towards me. I think when we do that, you can either do it in the like kind of like the preoperative room before going into the induction room, or before like the medical team comes in to do that. you can bring a favorite stuffed animal for them and have them put the mask on the stuffed animal too. So for that medical play aspect, inquiring from the medical team, like, hey, can we get like an extra mask in here, like a baby mask for my child's bear, so that we can kind of practice on the bear first. So you can have the child put the like mask on the bear first and have them be like, okay, we're taking in a big deep breath in, deep breath out, and like have the bear try it. Or even if you're comfortable as like the guardian or caregiver to be like, hey, can I have like my own mask? And it doesn't always have to be with like a teddy bear, but it can also just be like a parent or guardian like demonstrating on themselves, like, okay, here's my mask, I put my special stickers on it, and we're going to take big deep breaths with it. So medical play is super helpful, I feel like, beforehand, especially if they're super anxious about it and have had a previous experience that was not positive and they like really had a hard time with it. Doing it either at home in a safe place before the MRI, trying to figure out how you would be able to get a mask, like an induction mask before then, but maybe inquiring from the medical team, be like, hey, can we get this, or like keep the one that we use today, or can we have this time, like when you're scheduling the appointment ahead of time with the team, like, can we have a little bit of extra time to kind of just work through this with a teddy bear or through medical play before we even kind of step back into that room and go through that process again, is super helpful. Any other questions? Alrighty, we'll move on to laser. Alongside the MRI medical play, I think it's super important to also do that for the laser procedure. So this is a picture of Moana, Moana doll. Here at LPCH, some of the options that we have for our patients is to offer appropriate choices. That's another huge thing that we encourage for our kiddos. Unless they're like super little, we'll typically do the laser kind of stickers on their eyes, which is what Moana is on the right side of the on the right side. For our older kids, sometimes we offer, okay, like, do you feel comfortable, or do you want to use the like special laser glasses instead of having the stickers? Because sometimes that can be a really big trigger for some patients, is that now they like can't see anything. So if in the case that we do use the laser stickers, trying to put them on until like right before we do it, like kind of hold off on putting them on until like right before we like kind of wrap like in your arms and kind of go through the procedure, I think is super helpful. And then immediately taking them off right after we're done. So after that last like pulse is done, okay, like, okay, we're ripping off the stickers and we're like kind of moving positions, and more to that like comfort role afterwards. And then having them kind of navigate that too would be helpful before the laser procedure or even after the laser procedure too. This is kind of what it would look like, a typical tray of what it looks like. And there's like a little bit of the preparation materials that we could use. One of the biggest things I feel like that's been helpful for our patients that undergo laser is either putting, so we have our EMLA cream, which is like our numbing cream. If you have not used that for any laser procedures, please, please, please check in with your dermatologist or your like PCP, like a primary care provider, to see if that's something that you can put onto the site prior to help with that like numbing aspect, to help reduce like the pain for these patients. Another really big thing that I found is really helpful is the cold packs, like an ice pack. So if you want to put it on the site beforehand, and then also you can like immediately right after the procedures, kind of putting that cool ice pack right over the site that we just lasered is super helpful. And then having a comfort item with the patient as well as they're going through the laser procedure. I think I have a picture of like kind of a comfort position on this side. So for a blood test, and this goes for like laser, but also for a like even for like a IV placement too, kind of having this like back, your back or patient's back against your chest, and then like kind of having their like holding their hand kind of like near their face, and just kind of talking them through it, or if, like give them the opportunity if they want to look, let them look. But if you are kind of like, no, my child will freak out once they see that needle, then you can like totally like just kind of block their vision like that. I think for depending on where the hemangioma is for the laser procedure, just kind of talking with your team to figure out what the best, what we call comfort positioning is. So whether that be like the back, your back or the patient's back against your chest, or even kind of doing like a bear hug position, depending on if the hemangioma is on like the lower extremities. Um, but kind of navigating what's the best position for whatever you're comfortable with as like the parent or caregiver, or discussing with the child like what would you be comfortable with. The most important thing is of course making sure that the like our kiddos' bodies are safe while we undergo this procedure, because we want that laser pulse to go or the blood test to go exactly where it's supposed to go. So just kind of helping educate them on, okay, like what would your jobs be during this procedure? I feel like kind of asking that question for kiddos 3 and up is helpful. I feel like a little bit younger, maybe even 2 sometimes, but asking them like, okay, what do you think your jobs are for today? For a blood test or for an IV or laser, one of the biggest things that I say is your 2 big jobs today are to take big, deep breaths, and then we'll practice with a bubble machine, to see like, okay, how many bubbles can you like blow towards me to help kind of reduce their anxiety. And then their second main job is to keep their body as still as a statue. And then they're like, I think I can, or like, no, I'm probably gonna need mom's help, or I might need dad's help, or anything. And so a couple of coping techniques that we can use, especially for like the needle procedures. And another procedure that I just thought about that I didn't include but might be super relevant for your kiddos is if we have to do any like biopsies or excisions, like at all. And so this would apply for those as well, is having a Buzzy Bee, having the cold spray, and the numbing cream. So these are a couple pictures of, there's 2 versions of what we call Buzzy Bee. Buzzy Bee is like a little tickle massage that you can put around the injection site or like near where the needle is going to go. You can see in the picture that the phlebotomist is holding the Buzzy Bee kind of on the upper side near the tourniquet. That's typically where for an IV or a blood draw that would go. I found for like other procedures, some patients really enjoy to hold it in their hand or like hold it near their chest, kind of like this, and that helps kind of soothe their body. But there's like 2 versions of Buzzy out there. This is actually, Buzzy Bees, something that you can actually purchase on Amazon. So even if your hospital does not have this, it's something that you can purchase on Amazon, and really cool. I don't think you guys can see it as much, but kind of in this area where this looks kind of like there's a little hole in between Buzzy on the side, that when the one that you purchase online, it comes with a cold pack. So it comes like with the reusable cold pack. So you can put it in the freezer and then kind of put it on there if you're doing any like injections at home, or also if if you're living close by to the hospital that you're going to and you're like, okay, I think it can last a little bit there, or just even asking for like an ice pack when you get to the hospital is super helpful. And then asking another question of like, okay, do you want to observe the procedure or do you want to be distracted, and like having like an iPad or have maybe their favorite book if they don't do a lot of screen time, and or what, or listening to their favorite song while they do it and closing their eyes is also appropriate choices. Something that I explain for a blood test or a lab test, a lab draw, is this is the test that helps figure out what's going inside your body. A lot of patients are like, isn't there another way? And I'm like, I wish there was another way. but here are some things that we can do to help make it a little bit easier. Another big thing that I offer is like a stress ball. So just having like a little squishy ball, whether it be like an Orbeez stress ball or what the kiddos like to call like a slime. They're called Nido, but kind of like a slime themed stress ball. And that's really big right now. Asking if a patient wants to know kind of step by step what's going to happen. Like, for example, for a blood test, asking a patient, okay, do you want to do Buzzy Bee or do you want to do cold spray? Do you want to have a countdown? Do you want to sit by yourself or do you want to sit with mom or dad or caregiver? Do you want to know what's happening or do you want us to tell you when it's over? Do you want to look or not look? Can we, and I always tell patients to like, one of your jobs, like those deep breathing techniques is also, okay, like I'm going to be here to help you take those deep breaths and help remind you to take those deep breaths. So even if there's not a child life specialist present, if there's two caregivers, like one doing the comfort positioning and the other one saying, okay, like I'm going to be the person to help kind of like reduce anxiety, have the, like, you know, our child focus on me as they're doing it. And like, if you're comfortable, like navigating and leading, you know, your kiddo through that is super big. For this picture right here, the same thing for medical play goes. Like if this was to help a patient kind of understand or like help prepare a patient for a lab draw and help educate like a parent, like, okay, how this is a comfort positioning that we can do for our kiddos. I was reading an article the other day actually that I think as little as 3 months you can have the, you know, as long as like the patient like is like strong with their neck, like they can kind of sit up and do a lab draw. But I found that even with my own phlebotomy team that they're more comfortable having the patient lay flat on their back. And so with that position, what you can do is if there's two caregivers, one be at like the head of the bed, kind of doing like a gentle stroke on the patient's head and speaking, you know, positive words into the patient, like, I'm right here, I love you, I'm right here with you going through this, you're not alone. And the other side of it is if your child is super distressed and like needs additional like kind of comfort touch from you to help, not necessarily like hold them down, but if they're like keeping their body safe, but not like kind of like holding them in a specific position that a lot of medical professionals tend to do, especially for, I feel like even 3 and up, just kind of leaning over their kind of like near their tummy is allowing them to kind of kick their legs whenever, or just kind of like leaning over a little bit is another comfort positioning. That way they can like physically see your face and let them like kind of, as long as they're not like hurting you in any way, there's no, I don't feel like, you know, something that some parents can advocate for that I encourage is we don't have to completely like restrain their legs, but if they're like just kind of help letting them express themselves that way, in a safe way, but also still being like, hey, like I'm right here, we're doing this together, I can like see you, this is what's happening, we're like, I'm right here with you. Sometimes patients just really need to hear that. It's like, okay, I'm not alone, my mom is here. And also reassuring them that these tests that they're doing, especially for our like FACE syndrome communities, like we're doing these tests to help kind of with the diagnosis, right? We're trying to figure out what's going on so we can help your body feel better and help give your body like all the medications and things that it needs to feel a little bit better. And I think just saying that to some of our kiddos is really helpful, because they're kind of like, but I don't want to do this. And just validate that feeling. It's like, I hear you. I know you don't want to do this. Do we need like a minute to kind of just go over our plan again, or just kind of just sit here in this moment and then start the procedure, and just kind of help them navigate through those feelings. Don't ever like dismiss their feelings, or if you hear of a provider being like, oh, it's okay, it's not going to hurt, you can be like, no, it might hurt, you know, and you can tell us after you're done with it, how did it feel for you? What can we do to make it a little bit easier next time? And how can we best support you through this next time? Or what did we do this time that when we were supporting you that was not helpful? Like, did we talk too much, or did we say something that like made it like that like hurt your feelings, or you know, just like having those like debriefing conversations. And with the younger kiddos, it might be like when you guys are at home and they come home from the blood test or the IV or the MRI, and they're like, that was scary, and just kind of allowing them to kind of sit through that with you is super helpful. And then these are a couple, we like kind of talked about them, but this is like the coping toolbox that I encourage parents to do, is having that like not only just medical play, but facilitating space even in their kind of appointments, bringing their favorite toys with them. So like that therapeutic play. If they have their favorite Iron Man toy, Spider-Man toy, or Disney princess, or Spidey and Friends, anything that they really enjoy. You could even do medical play or just therapeutic play on that, like action figure too. And then we also have like our deep breathing techniques. Some of the examples that I choose for that is like, okay, we're taking our big deep breath in to smell flowers, like your favorite flower, and then deep breath out to blow out your birthday cake. Another deep breathing one is doing box breathing. And so it's kind of drawing like an imaginary box with your fingers. And so having the patient take a big deep breath in, going up, and then deep breath out, and then having them follow the like your finger to the side, and then another big deep breath in, go down, and then deep breath out. You're kind of making a square with it. And you can do it as much and as long as like a patient needs, to kind of help reduce their like anxiety. And when I say reducing anxiety, it doesn't mean like the tears need to stop flowing, but just making sure that they're not going to pass out and they're not like hyper, what's the word? Just like hyperventilating and just kind of really making their body like could be like really, really intense for them to be like, okay, like we need to just like take big deep breaths. Like we're here, we're gonna get through this. And then allowing them to still have their, you know, their tears flowing. That's okay. And then bringing in their favorite comfort items. That not only goes for like patients, but even if you're admitted into the hospital, something that I really recommend for our kiddos is, and their parents, is bringing in your own comfort items too. Like if you have your own favorite things that you enjoy that helps bring you peace and calm, then please bring those. Highly encourage those. Yeah, I think, yeah, these are just the references. I'm gonna try to exit out so that I can see the comment section. But any questions for me about anything that I talked about?
Alyssa, thank you. So many good ideas that you have given families. Whitney actually has been posting all sorts of shopping links in the chat. So all, so everybody could just grab those links. I'll grab them too and try to send them out. But we're like different things for different medical play and for getting, you know, masks and so forth and so on. So she's, you know, been supporting that as well. Does anyone, are there any other questions for Alyssa? No, thank you. Thank you so much. Your ideas were amazing. I'm sure that other families, you know, will benefit from hearing these ideas as well. And thank you so much for joining us again. It was nice seeing you again.
Of course, of course. Thank you so much for having me. And if there's any other questions that come up, please feel free to inquire. And I have no problem like sharing my slides later on after as well.
Awesome. Thank you. Thanks again. All right. That was good. I really love when Alyssa comes to talk because I feel like we can all use no matter what, whether your child has face syndrome or whatever. I think it's always beneficial. So I think it's great information. All right, Dr. Orbach. You
Hello.
are up. Hello, how are you?
I am good. That was a tough talk to follow, so thanks for setting me up like
Well, thank you.
that.
Alyssa did great.
All right, hello everyone. I'm Darren Orbach. I'm a neurointerventional radiologist. So I'm part of a cerebrovascular team that works with neurosurgery to treat blood vessel problems in the brain, not just related to face, but related to all kinds of things. I know many of you, and it's great to see you, and I don't know many of you, and it's a pleasure to meet. I was going to focus on brain vascular issues in face, and I'm happy if people want to interrupt me while I'm speaking or ask questions at the end, whatever it is. The bottom line is I want this to be helpful and understandable. So you all know the acronym, of course, and I made the hemangioma line a little bit larger because I'm going to talk about it briefly, but really from a brain perspective. How does the hemangioma interact with the brain itself? And then I made the A line, the arterial anomalies, quite large because that's what most of this talk will be about. And I'm going to go through what kind of arterial anomalies we see in the brain. And I was actually going to propose a slight change to the name by adding another A, because I really want to distinguish between two different A's. One is the arterial anomalies that we're all familiar with in face, and the other is something called arteriopathy, which is actual aggressive problems with arteries that certainly can occur in kids with face, but also occur in kids without face. And it's really important to distinguish those from the arterial anomalies of face. So I'm going to show you examples of all of that. So let's jump in just to start with the hemangioma. And of course, you're all very familiar with infantile hemangiomas. But looking at this photo from a cerebrovascular perspective, you have to ask yourself, what is possibly going on underneath? Not at the skin and not the layers just below the skin, but really far underneath. Can hemangiomas in this location that define the whole syndrome actually interact with the brain itself? And let me show you some images. So this is an MRI scan. Just to orient you, this is the front of the head. You can just see the nostrils up here, and this is the back, and here's the back of the brain over here. There is actually hemangioma that appears on this image. It's a little bit subtle, but once they give IV contrast, it lights up like a light bulb. Hemangioma takes up contrast because it's so vascular, and you can see this white, fluffy material here inside the brain. So here's the brainstem, and the back of the brain, the cerebellum, and here's hemangioma insinuating itself within the brain itself. It was actually here too before they gave the contrast, but the contrast really lights it up. And for those of you who are very good observers, you'll notice that there's actually some hemangioma here on the surface. So you can see on the back of the neck, on the back of the scalp right here, there's asymmetry. The skin is thinner over here and it's thicker over here with that same bright signal as the signal here in the brain. And if you go to a different level in the same patient, these are all the same patient, you can see the hemangioma over here. So this is a phenomenon that we definitely see. Children who have infantile hemangioma on the skin or on the surface somewhere, it can definitely infiltrate through the various cavities of the skull and get into the brain. And it typically does exactly what this does. It does not invade the brain. It does not really invade the brain tissue in any way. It doesn't really interact with the blood vessels in any way. And we looked at this systematically a long time ago. And this is aptly called the tip of the iceberg phenomenon, of course, because what we're seeing on the surface is often just the tip of the iceberg. This was actually the very first paper that I wrote at Children's years ago. This was the first project we did, which was to look at what happens when hemangioma actually gets into the brain. And you could see we looked at our cohort of patients with large hemangiomas in our vascular anomaly center, and we found it was about 1% of them had involvement of either the brain or the spine. And interestingly, there were no cases in our cohort of brain tissue signal abnormality, neurologic abnormalities from the hemangioma, no hemorrhage, nothing like that. So that's a very important principle. Here's a similar case, but on the back. So this would be an example of lumbar, not face. But here's the hemangioma on the surface. And here's the MRI scan. And this is a sideways view here. So here's the skin on the back. And then here's the spinal cord, this gray line here, and the vertebral bodies. And you can see there's soft tissue in here, just behind the spinal cord, and there's soft tissue up here, just in front of the vertebral bodies. This is a frontal view, and you can see this hemangioma right here surrounding the spinal canal. And here, this is sort of the view from below. And you can see the hemangioma in front, around the cord, and behind the cord over here. And then the behavior of the hemangioma around the brain and the spine is just like the hemangioma outside. So as the child grows and the hemangioma involutes, or in response to propranolol or other medication, the hemangioma goes away. So this is the same patient at 4 months and 4 years, and you can see the hemangioma is now gone. So for the classic hemangioma of face, even when it gets into the brain tissue or around the spine, it seems not to have negative neurologic consequence. So that's the hemangioma piece. I'm now going to turn our attention to the arterial anomalies of face. And just by way of background, this is literally the textbook diagram of the circulation to the brain. And you can see that this is within the brain itself. It forms an actual loop. This is called the circle of Willis, and it connects the right side and the left side arteries and the front and the back arteries. So these arteries in the front come from the internal carotid arteries, which split into the middle cerebral and anterior cerebral arteries. And then this is the back arterial system, the vertebrobasilar system. This is the basilar artery here. And the front is connected to the back by these two posterior communicating arteries. So before we launch into the actual findings that we see in face, I'll just briefly go over how do we actually look at the blood vessels of the brain and the head and the neck. There are various techniques we have. One very good one is CTA, so that stands for a CT angiogram. It's done in a CAT scan machine. It has lots of advantages. First of all, it's very fast, so the scan can be done in less than a minute. It gives you really nice high-resolution images of both the arteries and the veins. And as you can see from this picture, it gives you very nice anatomic relationship between the arteries and especially the bones. You can see beautifully where the various vessels are in relation to the skull and the skull base. You do see soft tissue as well, although you really don't see the soft tissue anywhere nearly as nicely as you do with MRI scans, which I'll show you in a minute. So that's one of the downsides of CT, is that the visualization of the brain tissue itself and the spinal tissue itself is not as good. And of course, it involves X-rays. CT always involves shooting X-rays at different angles. And therefore, we try to avoid it as much as possible in young children, although it still remains a very useful technique even in young children for certain indications. MRI does not use X-rays or any form of radiation. Instead, it uses magnetic fields by a complicated process to generate these images. And because of the way it works, you can actually coax the machine to generate very different kinds of pictures that bring out different features of the anatomy. So here on the left is a classic image. This is called a T2 weighted sequence. And you can see the great detail of the brain tissue itself. You can see the cortex and then the connecting white matter inside. You can see the ventricles in the brain, the fluid-filled structures. So this is a beautiful all-around view of the brain. But you can then ask the machine to generate special sequences that look at things like blood products. So these are all the same patient, actually, but the MRI scanner has drawn out different elements from the pictures. This is the all-around anatomic view. This view is great for looking at blood products, and you can see that this patient has blood products here in the frontal lobe and here in the corpus callosum in front in the band connecting the two hemispheres. It's here, but it's very, very subtle on the general scan. And then this is an MRA, same machine, but just extracting the blood vessel information from these same images. So lots of advantages to MRI. The downside, and there's no harm, let me just add, to the body from getting an MRI scan at any age, even prenatal. And in fact, we do lots of fetal imaging now. This is not a patient with faces, but just to show you, these are fetal scans on a patient with a different kind of vascular anomaly in the brain. So fetal imaging has become very important. That's largely MRI based for looking at the brain. The downsides of MRI is that they're slow, so it takes time, sometimes more than an hour. And that means that pretty much in every case with young children, there will be sedation, as came up in the questions from the prior talk. There are some restrictions on MRI, so patients who have mobile metal fragments in their body or some implanted devices that don't interact well with the magnetic field of the scanner, they cannot undergo MRI. And then the view of the vessels are not quite as high resolution as the CT. So you remember the blood vessels on the CTA were very clear. The soft tissue of the brain was not as clear on the CT, but MRI is kind of the opposite. The blood vessels are quite good, but not really as sharp as the CT, although the soft tissue of the brain is great. And then the last technique is also the oldest, so cerebral angiography. This is an invasive procedure where we put a catheter inside the arteries and we inject contrast, which gives very detailed views of the blood vessels of the brain, the most detailed view we can get. And also, very importantly, it actually shows the blood flow, not just a snapshot of what the vessels look like, but we actually watch the blood go through the arteries, into the brain tissue, into the veins. The downsides are it requires general anesthesia, it is an invasive procedure, and it does involve x-rays. So that's how we generate those pictures. This is a schematic showing the course of the catheter. We almost always start in the femoral artery in the upper leg here, and then the catheter is navigated up the aorta to the base of the neck, and we go into each of the vessels that goes up to the brain, and the catheter stops here, and then we inject dye, and that's what gives us the pictures, which I'll show you in a moment. Just parenthetically, the other major advantage of cerebral angiography is it then allows us often to treat various conditions, and this is most of what I do, is we then put smaller catheters through that first one, microcatheters that don't stop in the neck but go all the way up into the brain, and we can treat various kinds of conditions with specialized tools that can be introduced through the catheters. So that's cerebral angiography. This is what the images look like. So this is the same patient. This is a frontal view. You're looking right at the patient. And this is a sideways view, a lateral view. And you see the crisp anatomy of the blood vessels, even these tiny little vessels that are almost like a hair, which you would never see on a CTA or an MRI. But you can see that you don't see anything else. We're not looking at the brain, we're not looking at the bone, because the computer extracts everything else and we just see very high resolution views of the blood vessels. These are the same patient, same set of images, but this is an early image looking at the arteries and a late image looking at the veins. So we really get a nice crisp image of all the phases of the angiogram. All right, now we're finally ready to jump into back to what are the arterial anomalies in FACE. What I want to stress is these anomalies are almost all static and fixed. It's a little bit like an unusual fingerprint that the patient has that doesn't change very much over the course of life. And if the patient is acclimated to it from the beginning, they likely will stay acclimated to it through life. So what kind of anomalies do we see? There can be agenesis, which means absent vessels. There can be hypoplasia or stenosis, which means tiny, tiny versions of what should be a much larger vessel. There can be persistence of vessels that usually go away during fetal development, but in some FACE patients, they do not go away, they persist. There can be tortuosity, which is the twistiness of the blood vessels, and there can be dysplasias, which are where the vessels don't have the classic cylinder shape, but instead they're large and very irregular in shape. And I'll show you some examples. So this is that textbook picture. It looks very symmetric, right to left and front to back. And here you can see this is one of those persistent fetal vessels. This is a trigeminal artery coming from the internal carotid artery and going right to the basilar artery. Here's the top of the basilar artery. Here's the top of the basilar artery on the schematic. And you can see this patient actually doesn't even have a lower basilar artery that you can point to. Instead, the flow is coming from this trigeminal artery. But is this a problem for this patient? It's really not. The patient is getting adequate blood flow. It is important to know this patient's anatomy, but it's not really a problem in terms of this patient's brain function. Here are other examples. You can see this is one injection on one side of the brain in this patient, and you can see how there's a very good filling of this side and some cross-filling to the other side. When you inject the other side, same patient, look how different the anatomy looks. You have the internal carotid artery has this very unusual course and gets very narrow, then it does a 360-degree loop, and then finally it gets to the brain. Again, other examples in different patients. This is an internal carotid artery that is absolutely tiny in this patient. You see it's like a thread that really is not supplying the brain at all. And instead, the supply is coming from alternative vessels in this patient. This is a different patient, and this is showing that there isn't even really a single artery from below that's sending the blood up to the brain. Instead, there's a tangle of these much smaller vessels that coalesce here in the neck, and then they come together and finally supply the brain with its blood supply. This is another patient, and you can see this is the basilar artery, which is this main artery in the back over here of the brain, and it's actually completely truncated. This is the lower basilar, then it's cut off, and here's the upper basilar. So totally not what we expect from the textbook, and yet this patient is doing fine in terms of blood flow because the flow is reconstituted by these bridging arteries on the right and the left. And then finally, this is an example of the dysplasias that I was talking about. You can see instead of a smooth cylinder, you have an unusual course with narrowing, and then the vessel enlarges and then becomes this very complex, quite enlarged dysplastic segment here. And we'll come back to this in just a few minutes. I want to distinguish all of that from the second A that I proposed in the name here, which is arteriopathy. And that these conditions, unlike the static anomalies that we see in FACE, these conditions are actually progressive. They change over time, and they can be truly dangerous. So the main one is the first one I'm going to talk about, which is moya moya, and then I'll mention aneurysms at the end. Moya moya is something we see a lot at Boston Children's. We're a moya moya center. It is a condition in which there is progressive narrowing of the large arteries of the brain, usually the internal carotid arteries and the middle cerebral artery. In conjunction with that, there's proliferation of what are normally tiny little deep perforating arteries. And the risk to the patients is a very high risk of having strokes or chronic injury to the brain tissue because of the decreasing blood supply as the arteries narrow down. And as I said, we see a lot of moya moya. The vast majority of patients with moya moya do not have FACE. This is an MRA in a patient with moya moya, and you can see you're just missing the large arteries up here in the brain. Here we are in the neck. Here's the bottom of the arteries coming up. You see some arteries in the middle, but the whole tree is missing on both sides. This is the view from below, same patient, and you can see all of these little dots in here are these perforated vessels that have proliferated to try to somehow compensate for the loss of the big arteries. And there are other signs of decreased flow in the brain on different MRI sequences. This is moya moya presenting in one side in a patient, and you can see the asymmetry in the size of the arteries here. This is what the angiogram looks like in this patient, and you can see the stroke that occurred in the presentation of this particular patient. This is moya moya at its extreme. So here's an angiogram, frontal view, and sideways view, a lateral view, and really loss of all the arteries going to the brain here. This is the internal carotid artery coming up, and it just terminates in this small tuft of little vessels. You can see that on the sideways view here. Really very inadequate for supplying the brain. And therefore, the treatment for that is actually a surgical revascularization, usually with a technique called piosynangiosis. These are the arteries outside the brain, and they're actually brought down into the skull to supply the brain blood supply from outside. Why am I bringing up moya moya? Because there is no question that the form of progressive arteriopathy that FACE patients get is moya moya. So the ones we really worry about, high risk of stroke, are the FACE patients with moya moya. We have found that in our cohort, when there is moya moya and FACE, and moya moya occurs only in one side in that patient, it is always on the same side as the hemangioma, which is a fascinating finding. I will say that moya moya usually progresses to involve both sides of the brain, although definitely not in every single case. And then the last condition I wanted to talk about are true brain aneurysms. And this is a patient who does not have FACE, but does have a brain aneurysm. This is a frontal view. This is the basilar artery. And you can see how wide this one area of the artery is here. It's ballooned up a little bit. This is the view from below. This is what this looked like. So this is what it looked like at its appearance. And then 16 months later, this is what it looks like now. So you can see how much enlarged it has become. It has a daughter dome over here. This is the view from below. This is the sideways view. You can see that it's compressing the brainstem. This is a major risk to this patient of hemorrhage. and also of just compression of the brain, just from the growing aneurysm. So this is a big problem that needs to be addressed. And the reason I'm showing this is to contrast it with the dysplasia of face. When you first look at this, this is the angiogram I showed you before. This sort of looks like a complex aneurysm you have in large segments of the blood vessels. This would be a very complex aneurysm if that's what it was. But what we have learned through the years is that these dysplastic segments in face patients do not seem to behave like aneurysms. In the great majority of cases, they seem to be static. We do follow the patients very carefully with surveillance images, but unlike that aneurysm I just showed you, they do not seem to grow over time. I just did a quick numerical breakdown of my own case log for this talk, and I looked at my personal database of 2,240 angiographic procedures in 1,111 children. And out of those 1,111 children, 22 of them have FACE. So that's about a 2% rate within my own practice and our cerebrovascular practice at Boston Children's. Why did we do angiograms in those 22 children? Overwhelmingly, the great majority were for moya moya. So it's a very specific subset of kids with FACE where we're really worried about moya moya, and there we need to do the angiogram to extract information for surgical planning. Some of the cases, 5 of the 22, were really just to clarify the complex anatomy where we were worried, was there adequate blood supply to the brain or not? We were trying to tease apart, was something just a dysplasia or was it actually an aneurysm? And then I've had one case of an arteriovenous fistula, an AVF, in a child with FACE, and that remains the only case that I have had. So AVF is not a feature that we see in FACE with any regularity at all. So just to tie everything together, we saw that we started with the infantile hemangioma itself, and we saw that even when it infiltrates into the brain and around the brain or the spine, it does not seem to pose clinical risk in the great majority of cases, and that it responds to treatment in the same way as the extracranial piece of the hemangioma, the superficial piece that you all see. We saw that although FACE involves very unusual configurations and pathways of the arteries to the brain, there can be absent vessels, dysplastic vessels. In almost all cases, these findings do not seem to correlate with strokes or bleeding in the brain, and therefore the recommendation for the great majority of patients is just surveillance MR imaging and not angiography and not procedures to fix the unusual configuration. Consultation with neurointerventional radiology and neurosurgery for potential treatment is really reserved for those few patients who have moya moya or where we suspect moya moya or true brain aneurysms. And so the key distinction that I tried to make is between the arterial anomalies that are very common in FACE and true arteriopathy, those progressive conditions that thankfully are much rarer. And that is it. I'd be happy to answer questions.
Thank you. Wow. I learned a lot. Amazing. All right, folks, what do you have for questions for Dr. Orbach?
Hi, doctor. Just would love your advice on what you've learned regarding aspirin use for FACE patients.
Yeah, so I'll start by saying in the subset with moya moya, we always use aspirin. Essentially, every patient we have with moya moya, with FACE or without, is on aspirin, because when blood vessels get to a certain degree of small caliber, where we're worried that it's a setup for the formation of clot, aspirin acts as a gentle blood thinner and lowers the risk of forming those clots and therefore having strokes. So even after we've treated moya moya patients surgically, they stay on aspirin for life. We have had patients with FACE who have unusual arterial configuration with small arteries, but it's not progressive. And sometimes the supply to a particular part of the brain is questionable. Even though it's not progressive, we may do an angiogram to really clarify. If the flow is not super brisk and we're a little concerned, we have definitely had cases where we feel better putting the patient on aspirin as a way of lowering the risk of forming clots, just like with the moya moya patients. But I will grant you that I don't know of a rigorous study to show that. And I can't even say that there's a strict guideline that makes us pull the trigger. It's really a case-by-case assessment of how tiny is that blood vessel and are there alternative sources of blood supply or not.
Thank you, doctor. And then I guess it's case by case, but have you seen some of your patients being on this medication or aspirin or blood thinners for the duration of their life, or is it only for a time period?
So if the treatment is because we're worried about the configuration of the arteries, then it would be for life. It's actually seems to be very well tolerated. As I said, we have a big moya practice, and all of those kids are on aspirin for life. And it's, as I said, there's really minimal trouble for those kids. So it's not in response to a particular, sometimes you might do a course of aspirin for a limited time period if there's an infection risk or something where you think the clotting is likelier. But if it's just to treat the anatomy, then it would be for life, yeah.
Thanks, doctor. And just last question is the frequency of the imaging. We feel like we had several in the beginning of my daughter's life, but it's kind of lessened as she's gotten older. Any recommendations on the frequency of imaging?
So that's usually the course, is exactly what you described. At the beginning, the imaging can be more frequent, especially when you first see narrowed vessels. It's not clear just from a single set of images whether that's the patient's anatomy and that's the way it's always going to be, or is this early moya and we're now seeing the vessels start to narrow and we better make sure that it's not progressive. So the way to ensure that is to get a follow-up set of images. But once the anatomy is pretty stable and the child is growing well and functioning neurologically and not having any episodes, even with physical activity, that are worrisome for inadequate blood supply, at that point, you don't need to keep following to check to see that something drastic has changed. It probably does make sense to do some surveillance imaging through life at some low frequency because we're all still learning about these unusual anatomic configurations. And I could not tell you right now what happens at age 50, for example, compared to age 30. Once a child is old enough to do an MRI scan without sedation, which is usually around age 7 or 8, then there's really no downside to MRI scans other than the hassle factor and the time. There's no medication and there's no x-rays. So it's sort of an easy thing to do. And at some frequency, it would make sense through life, I think.
Thanks so much, doctor, and especially your presentation. It really hit home with us. You might not realize it, but you're one of our many opinions, and this presentation would have served to be really helpful for some of the specialists we saw because so many people were so quick to do the invasive procedure. And so because of our consult with you and your team, we actually delayed it just based on your experience with this syndrome. So thanks so much from our family.
Thank you.
Hello, doctor. Good afternoon.
Hi.
Just wanted to ask, like, Dr. Moya, can it develop at any age in FACE patients, or if it's present, it's there?
That's a great question. So moya in general actually has two peaks of presentation. The one that we treat at Boston Children's is the pediatric version, and that basically happens anytime from birth on, but the peak is really around age 2 or 3. That's when children start to develop symptoms. And the major risk of the moya there is actually ischemic stroke. So they have strokes. There's another peak of moya which occurs in adults. So we don't see it at Children's Hospital, but in the world literature, and if you look at adult hospitals, when they see moya, that occurs in the 30s, 40s, 20s, 30s, 40s. And that more often presents with bleeds in the brain than ischemic stroke. Angiographically, the images actually look the same. So I don't think you could look at an angiogram and say this one is a pediatric version and that one is an adult one. And there's some debate over whether it's the same entity or they're just two conditions that look the same on the imaging, but there's actually a different underlying problem. Why one presents with stroke and the other with aneurysms? Probably it's because after many, many years of having moya vessels, the little vessels that have proliferated to try to compensate just can't sustain arterial pressure for many, many years and decades, and they finally give way and cause hemorrhage, which we don't really see in children. So that's moya patients in general. The moya that we've seen in FACE patients has always been the pediatric version because that's who we're seeing. And I'm actually not aware of anyone who's studied FACE adults with FACE and have moya that's newly presenting. I don't even know if I've ever heard of a case. I don't know if any of my colleagues are on who has heard of a case like that. And it would be interesting to know if that patient presented with ischemic stroke or with hemorrhage. I actually don't know.
Thank you, doctor. So doctor, if till the age of 3, the angiogram is stable or the MRI images are stable, then we can be at a little peace. But yeah.
Well, the peak is at age 2 or 3, but kids develop moya actually later on as well. The flip side, though, is of all the kids with FACE, moya occurs in a small fraction. So it's not something I would walk around worrying may happen. In the great majority, the configuration that you see by age 1, 2 really is a static configuration, and moya is unlikely. I would not say impossible. I basically never say never in my job, but it's quite unlikely at that point, I would say.
Thanks a lot, doctor. And doctor, just one more thing, like if the MRA shows a thickening around the vestibulocochlear canal, so can it lead to any hearing impairment in FACE kids? Like my daughter had a diagnosis of a suspicion of hemangioma around the canal because of the thickening there, and it decreased afterwards, like in the second MRA and all. But
Yeah.
had a recent ear examination.
So hearing loss is not rare. It can definitely happen in FACE, but as I said, the hemangioma itself, so far as I'm aware, does not contribute, at least from a vascular perspective, to cutting off blood supply to either the cochlea or any other organ. So my guess would be that the mechanism would be different in cases that there's hearing loss. And the majority of kids who have hearing loss have never had hemangioma around the canal there. So I don't think the two are likely related.
Okay. And doctor, is middle ear function abnormality common in kids with FACE?
I am not aware of a particular connection there, but I have to profess that I'm not aware of a connection, but that doesn't mean there isn't one.
Fine, doctor. Thanks a lot. Thank you.
Do we have any other questions? Everybody's thinking hard. Full day. That was amazing. Thank you so much, Dr. Orbach. I really appreciate you coming on and doing that. I certainly learned a lot. Being with the organization for just 4 years, there's so much to learn. Your presentation was really clear. I'm sure there are families that have a chance to view it later will understand more as well. So I appreciate you.
Thanks very much. Take care.
Welcome. Thanks. Okay, Dr. Vassar, you're up.
Perfect. Hi, everyone. I am Dr. Rachel Vassar. I am delighted to follow that amazing talk by Dr. Orbach, and I think that it will pair nicely with what I'm going to share. I'm a pediatric neurologist at UCSF, and I also am specifically a pediatric vascular neurologist. So I'm very interested in all types of kind of genetic cerebrovascular diseases or malformations, including FACE syndrome. So I really am appreciative of the chance to talk today. I know everyone's probably been sitting and getting a little bit restless perhaps, so I like to make things as interactive as possible. And I just wanted to start by sharing a brief poll. Hopefully people will be able to participate in this, but I realized coming off that talk, stroke may be at the forefront of everyone's minds, but would love to just quickly poll the group on kind of what your main concerns are related to FACE syndrome and its effects on the brain. You can use this QR code with your phone, and the votes as they come in should start to appear. Well, I know that there's, oh, more things are coming in. Well, this is really helpful and interesting to see. And I think, this fits with what some of the research has shown that, everyone, of course, is thinking about stroke, but in fact, the more common manifestations of FACE often are other things that kind of affect patients day to day, such as headaches, potentially the developmental delays. Great. Well, I know that not everyone probably has gotten the chance to comment, but this, I think, sets up a good foundation for what I will talk about, and I will try to touch upon all of these things, although obviously I know there's a lot to say about each of these topics, so thanks for everyone's votes. So I am going to talk today about the neurologic manifestations of FACE syndrome, and we've had several excellent talks today, already kind of talking about the research of this and the spectrum of different vascular malformations that can be seen. But I'm going to focus today more on the clinical management of some of these neurologic symptoms. So based on research done by multiple people who are on this call, including Mitchell Braun and the FACE group, particularly at Stanford and UCSF, we have some sense of kind of the frequency of these neurologic symptoms in patients with FACE syndrome. In the cohort that they published this year, 72% of FACE patients had headaches, including migraines, and about half severe enough to require referral to a pediatric neurologist. Learning differences were present in 45%, although the majority of those patients just had mild differences. Seizures were present in 14%. Unfortunately, stroke was only observed in 2%, or it was 2 patients. And one of those patients, as I believe that Dr. Braun mentioned earlier, was actually in his 60s at the time of stroke presentation. So though, of course, stroke is a very scary, thing to be thinking about, fortunately, it's a very rare feature of FACE syndrome. And then, of course, there's other neurologic symptoms that can come up, including kind of paraneurologic symptoms such as vision difficulties and hearing loss, as we were talking about. And I think it's important to know about that just because you see that they're relatively common features in FACE syndrome and worth screening for in all patients, I would say. So how does FACE syndrome impact the brain? I won't go into details about this because we have already heard a lot about that, but we know, in simple terms, that it can cause structural brain differences as well as arterial abnormalities and other types of vascular malformations. Now, many people ask why. Well, unfortunately, we still don't really understand why this happens in FACE syndrome. We believe that it happens very early on in development in the fetus, possibly due to changes in blood flow that are early on, like in the first few weeks of fetal development. And, one thing that we don't know is what we can't see underneath, at the actual cellular level in FACE syndrome and what is beyond the resolution of an MRI. So there may be differences in brain connectivity or signaling that we don't fully understand yet, even apart from the structural or blood vessel abnormalities. So just wanted to give a brief disclaimer that, of course, all of the following guidelines are kind of just general advice, and it's important to involve a neurologist in your team if you or your kid has any abnormalities in their brain or blood vessels, because every case, as we have already discussed, is unique and warrants kind of individualized recommendations. So, though, of course, I mentioned stroke and cerebrovascular complications are rare, of course, they're on everyone's mind. And as a pediatric vascular neurologist, it's something that I'm thinking about every day. So we do have a way that we classify different vascular findings in FACE syndrome, and I'll show you the table about that from a paper on the next slide. But so we do have some ability to take an individual's specific blood vessel abnormalities in FACE and try to give a sense of whether or not that individual is higher or lower risk for stroke across their lifetime. Of course, that risk might change if they have kind of a progressive type of blood vessel abnormality, but in about 2/3 of patients with FACE, we think that the blood vessel abnormalities are just fixed or, static abnormalities that are not going to change over the span of their lifetime. As we touched upon a little bit in Dr. Orbach's talk, as well as one of the great questions, there's possible decreased risk of stroke with aspirin. And this is something that is definitely going to benefit from larger studies. We essentially are extrapolating from other conditions to consider that aspirin also might be helpful in FACE syndrome. But again, there's been no formal studies of it. I don't think that every patient with FACE syndrome needs to be on aspirin, but it's very individual based on the specific blood vessel abnormalities in the brain. And again, is why it's worth talking with a pediatric neurologist, and if possible, even a pediatric vascular neurologist, though we are few and far between. We think that, in the 1/3 or so of cases that might have progressive vascular abnormalities, we think that these changes generally are occurring very slowly. And this informs our frequency of imaging recommendations that, we don't expect this is something that's changing over the span of a month or two, but it can change over the course of several years. And so in general, the current recommendations are to get kind of a baseline MRI if there's definite FACE syndrome suspected based on an infantile, hemangioma. And then, based on the imaging, potentially repeating a scan in several years to see if there is any progression, of course, sooner if symptoms, but then again, kind of waiting until the kid can tolerate repeat imaging without anesthesia. Moya, as Dr. Orbach discussed in a little more depth, is we think a rare complication of FACE syndrome. In the cohort studies that are published, less than 10% have moya. And fortunately, we can catch it before it causes problems and intervene. And so it is helpful to catch it before there's been an ischemic stroke, because we will, consider treatment and with the goal of preventing someone from having an ischemic stroke. It's important to, know about the signs and symptoms of stroke, and then future directions I think that we're all excited about or are more advanced imaging models, including looking at exactly how the blood is actually flowing through vascular abnormalities to try to further risk stratify whether a patient is at risk for the vascular abnormality changing or causing a stroke. This is the table. I know it's busy, but it's in this publication, Garzon, that helps to kind of risk stratify the different vascular malformations. So you'll see that there's low risk, intermediate, and high risk types of vascular malformations. Not every patient with FACE syndrome's abnormalities necessarily fit neatly into one of these categories, but it can help guide, the likelihood of progression and the need for involvement of a pediatric neurologist or vascular neurologist. And then also for the high risk individuals, probably aspirin is helpful. Whereas, in the low risk individuals, I at least am not universally recommending aspirin. So as I mentioned, signs and symptoms of stroke, I think it's important for everyone to know about these, not just because of having a kid with potential vascular abnormalities, but also because, stroke, it can affect people across the lifespan. People often don't realize that kids also can have strokes. And so it's important, particularly as a parent, advocate, if you are concerned that your child is having a stroke, unfortunately, it sometimes takes a parent to really speak up and voice that, because some emergency providers or pediatricians might not actually be super familiar with the fact that kids also can have strokes. The signs and symptoms of stroke in a kid are similar to an adult. So we like to use the BFAST acronym with all of these types of symptoms that can be concerning for stroke. In kids in particular, you also want to consider if they have a new onset seizure. Kids can present with seizure as their first sign of stroke more so than adults. But also to remember that not every seizure is a stroke, of course. And then also important just to know that a very sudden onset headache, that's the worst headache of someone's life, that comes on with the snap of a finger, could be concerning for a type of stroke called a hemorrhagic stroke. Again, I say these things not to scare people, but just because it's important to know for general care. So as I mentioned, I think particularly if you find yourself having questions about your child's individual blood vessel anatomy, that it's worth talking to a pediatric neurologist. And then if you feel that they are not adequately answering your questions, I think it can be helpful to reach out to see a pediatric vascular neurologist. But of course, that requires usually going to a quaternary care center available only in kind of a few major cities in the US. As Dr. Orbach touched on, it's important to get imaging of the blood vessels, not just of the brain itself. And so usually that is in the form of an MRA for children. There are emerging ways of getting imaging of the brain without anesthesia. And so, for example, at our center, UCSF, we're really working hard to start doing more and more MRAs that are very quick scans, like 5-10 minutes, without the use of anesthesia in young children. So that's something that I'm hopeful that, I'm sure other centers are experimenting with this as well, but something worth asking if it's possible at your center. Of course, you sacrifice some degree of accuracy, but it's a balance of the importance of getting that information with also the risks of anesthesia. It's also important to discuss your kid's specific blood vessel anatomy if it is really narrow or has particular abnormalities with any anesthesiologist before you're undergoing sedation, as we know that kids with moya moya or really severe narrowing of their blood vessels are going to be at higher risk of having a stroke during a procedure such as anesthesia, because those procedures, oftentimes the blood pressure will drop during anesthesia. And in a kid with PHACE syndrome or any type of blood vessel narrowing, it's super critical to not let their blood pressure drop during a procedure. And then hydration is super key. I mean, it's important for everyone. The brain is mostly made of water, but in kids with abnormal blood vessels, in particular, keeping hydrated is key for prevention of stroke as well as headaches and other symptoms. And I'll talk a little bit about a few other neurologic complications because, of course, as I said, stroke is fortunately a very rare complication. We're trying to prevent stroke. So seizure is seen in a small subset of patients with PHACE syndrome. I'd say that, there's not a lot published about it in general. I believe that most seizures in kids with PHACE syndrome are likely due to structural brain differences that form a kind of a origin under which a seizure is more likely to occur. A seizure really is just a symptom of the brain being irritated. And so if the brain is formed in any structurally abnormal way, it has a higher likelihood of seizing. But, in kids with cerebellar abnormalities, which is generally the most commonly described structural abnormality in PHACE syndrome, we actually don't see seizures that come from cerebellar abnormalities. So it really is more about structural abnormalities in the supratentorial or the top part of the brain that could predispose a kid to have seizures. Of course, it's important to consult with a pediatric neurologist if there's concern for seizure as part of the presentation. So developmental delays, this is another thing that, a lot of my patients and parents with PHACE syndrome ask me about. And fortunately, many of you have already shared, and the research shows that in PHACE syndrome, developmental delays are relatively common, but almost always quite mild. we don't really understand why there is this association between developmental delays and FACE syndrome, because as Dr. Orbach mentioned, usually the brain itself is not visibly affected on brain imaging. Maybe the blood vessels are, but the brain itself is not. But again, I think there's probably potentially differences in in brain formation on a cellular structural level that might impact function that we're not able to see with any type of imaging that we have today, or at least not on a clinical basis. The keys for, kids with developmental delay, whether with FACE or not, is that it's, the most important thing is to get access to services early. And so getting early intervention, getting physical therapy, occupational therapy, speech therapy as soon as possible is going to be the number 1, 2, and 3 driver of kind of the long-term outcome. Getting an IEP through the school district can be really helpful for advocating for your kid. It's important to know that generally IEP evaluations, formal neuropsych testing, is something that you are legally mandated to be able to receive, but only through a public school. So sometimes if families are struggling to get the services they need through a school that is a private school, I actually recommend switching over to the public school district. Getting a neuropsych formal evaluation can be helpful. It can be, cost prohibitive because it's not always covered by insurance, but can help identify other symptoms such as ADHD, anxiety, depression that are relatively common in FACE syndrome, as well as the general pediatric population, unfortunately. And it's super important to kind of try to access mental health support early on, because that's going to really, just like early intervention, kind of help with the long-term outcome of those symptoms. And just some tips that I give to all of my families, navigating the process of, having a child, whether they are typically developing or not. Some key tips are, obviously, it's easy to look on the internet and see what, milestones your kid is supposed to be reaching. And I always remind people it's a spectrum, and the things that are published are usually the average time that kids reach those milestones, and that we as pediatric neurologists generally don't get terribly concerned unless the kid is like a few standard deviations outside of that spectrum. So like 3 to 6 months delayed on a specific milestone before we even really start to be terribly concerned. Looking out for early handedness is important. It can be an early sign of structural brain differences. So we expect a kid to not have a real hand preference before the age of 18 months. Being exposed to multiple languages is great and actually really helps with language development. Speak up early if you are, concerned about anything, and your first resource should be your pediatrician. If you already are seeing a neurologist, then also generally they will help talk to you about the different ways to get help if you're concerned. Looking out for local disability advocacy groups is key, because frankly, I think a lot of doctors tend to not be nearly as familiar with all of the community resources as other parents who are navigating the process. And then my last comment on that is just that, I always say, it's not about how fast a kid is able to reach these milestones. It's really about long-term their function. And, kids all develop at different speeds. And so whether they talked at 1 or 5, the goal, we want to support what their long-term function is going to be. And so just getting them the tools to help them reach that long-term goal is the best we can do to help support their development. And then the last thing I'll touch on is headache. And, as our poll showed and as research has shown, it's actually the most common neurologic symptom associated with FACE syndrome. Headaches are extremely common just in general. It's the #1 reason that patients are sent to a pediatric neurologist. And it seems to be increasing frequency just in general, probably due to screen time and other lifestyle issues in the 21st century. So headache is especially common though in FACE syndrome. And unfortunately, we don't really have any specific data for management of headaches in FACE syndrome, but in general, we recommend several general headache strategies that I'll touch upon in a moment, but a few things that are unique to the FACE syndrome community and other patients with blood vessel abnormalities. We recommend avoidance of triptan, so things like sumatriptan, or also called Imitrex, or rizatriptan, because they can have blood vessel narrowing effects that could be dangerous in a kid who has underlying vascular abnormalities already. It's, if you're on aspirin, again, that's just going to be a subset of patients with FACE syndrome. Avoiding NSAIDs like ibuprofen, naproxen is generally a good idea because they both can have a little bit of an effect on the thinness of the blood. It can be safe to be used on, sparingly, but just not very commonly. There's newer agents called CGRP antagonists for headaches that are very effective. They actually tend to dilate blood vessels, and again, absolutely no data on this, and particularly in FACE syndrome, but I think they're likely tolerated, but it's something that is worth discussing with kind of a pediatric neurologist, potentially with experience in headache or vascular abnormalities. But this is a great resource I recommend to all of my families of kids and teens with headaches, Headache Relief Guide. It's kind of a teen-friendly website to navigate to kind of understand all the different things that you can do to help with headaches that are not medication. I tell people that if we had a pill that could be as effective as all the lifestyle interventions for headache, we would be, winning the Nobel Prize. Because really it's about day-to-day lifestyle changes that are going to influence the frequency and severity of headaches the most. So what can be done, that is not these prescribed medications? So, I know that it sounds basic, but it's really, really true that these kind of 4 key things are critical to any kid or adult who gets headaches. And, increasing hydration is super critical, especially, when it's really hot out, when kids are really active. The website that I showed you on the last slide actually allows you to put in your kid's exact age and body weight and level of activity and figure out how many glasses of water they need to drink per day to stay hydrated. Nutrition is key, of course, a healthy diet and also avoidance of skipping meals. Sleep is huge for headache prevention, and, improving sleep hygiene is important, and then making sure that the kid is getting an adequate amount of sleep. And relaxation is also key. And, we live in a very stressful world, but we know that meditation, oftentimes getting a therapist is a really effective treatment also for helping decrease headache severity. And then these are the kind of first line things that I recommend as natural methods of helping with headaches. There's good data through large randomized studies, again, not in FACE patients, but just in pediatric patients in general, that magnesium is effective at helping decrease headache severity. Generally, you need to be at about 400 milligrams daily to see the benefit of that. Riboflavin is another vitamin B2 that is very effective for helping decrease headache frequency. Melatonin also has evidence that it can help decrease headache frequency. And so separate from its benefits on sleep, it actually can also help decrease with headaches. So, considering some combination of these is a very safe method and really can, actually make a large difference. There are some devices such as, I'm not endorsed by them or anything, but the Nerivio device is a FDA approved device that is kind of a armband that generates a little vibration that actually, for reasons I personally can't explain, is shown to reduce headache severity in kids and adults with migraine, both as kind of a rescue treatment as well as a preventative. So that's something to look into, talk to your pediatric neurologist about. And then lastly, I think, if headaches are in fact a significant feature of your kid's presentation, then it's always very reasonable to talk through strategies with your pediatrician. And then if they're unable to kind of answer your questions, then requesting that a pediatric neurologist be added to the team it can be really helpful. So I know that was a lot, but I wanted to make sure to hear kind of your thoughts and questions about the neurologic manifestations of FACE syndrome.
That was great. Wait, can you hear me? Yeah.
Yeah.
I had to put my AirPods back in. The battery went dead.
And I'm
That's
also just
awesome.
catching up on the chat, so I'll try to answer the questions in the chat too.
Yes, I was gonna say, I think that Jennifer put something in there. Oh, Aaron did too. Okay,
Yeah,
so Jennifer asked about, are there separate stats regarding the headache migraines for children who have had the revascularization?
Great question. I presume that is referring to kind of moya related revascularization. And as far as I know, there's nothing related to FACE syndrome and revascularization in terms of frequency of headaches and severity of headaches. I'd have to refer more to just like my general experience with patients with moya revascularizations for the broad range of conditions that can cause moya. And, you know, I think the goal is always that potentially revascularization can help decrease headache frequency if the headaches were thought to be partially related to not enough blood flow getting to that part of the brain. But migraines can also happen for very separate reasons, and it does not, like, your kid having migraines does not at all imply that they're not getting enough blood flow to their brain necessarily. So you know, people can get revascularized for their moya and have ongoing severe headaches, unfortunately.
Okay, and then Aaron, you have a question. Aaron, do you want to ask your question?
I can, and I'm not really sure it's for Dr. Vassar or anybody else, but because I know you were talking more about brain arterial abnormalities, but is there anything documented or any experiences with like peripheral vascular or arterial abnormalities there? Because it's been suggested that our son may have like intermittent claudication or low blood flow in his legs.
Yeah, that's a great question, and I'll give my thoughts, and then if anyone else on the call, the other clinicians have comments too, definitely feel free to weigh in. This is definitely a symptom that I have had patients report to me as well, both with FACE syndrome as well as other types of blood vessel abnormalities. You know, I think it's tough because we still don't really understand the actual molecular basis of like the why of FACE syndrome. And so I think that we likely consider it kind of a mosaic type of condition where probably some cells are affected and other cells in the body are not affected. Whenever someone has blood vessel abnormalities in the brain, it does make me more suspicious that they could have blood vessel abnormalities in other parts of their body. So that's why oftentimes getting an echo, looking at the blood vessels in the chest is critical. Sometimes looking at the blood vessels going to the kidney is important. And then potentially looking at blood vessels in the extremities. So, you know, I think that it's like, it wouldn't be through a neurologist that you would pursue additional workup, but there are ways, non-invasive ways of doing imaging of blood vessels in the extremities, such as with ultrasound, that could help, and then also MRI, although I'd probably start with an ultrasound, that could kind of better characterize whether there are, you know, blood vessel differences in extremities.
Yeah, this is Beth, and I would agree with Rachel. I've had a couple kids with FACE who have abnormalities of the subclavian vein and have had some decreased blood flow in that arm and some symptoms. So, and we do know from very rare cases where we've studied blood vessels in patients who have passed away, that it's a little bit more broader than we think. So, but one thing that I know that's probably not published, it is often the medium-sized arteries seem to be particularly affected. So that would be like looking at the femoral artery. And in fact, as Dr. Metry had mentioned, patients with lumbar syndrome often have very similar changes in the femoral artery that we see in the subclavian and in the internal carotid artery, either the aplasia or some of the tortuous dysplasia changes. So I think if that's happening, it would be worth, like Rachel said, just which they maybe have already done, but just trying to get some idea of some of the blood vessels there. It's not very common for sure that we see this, but it does make some sense, a little bit of sense that we might see something like that.
Yeah, the only two things I'll add to that is that, again, this is not like specific recommendations, but I think that there could be some evidence for like aspirin or doing something like a gentle blood thinner. If the question is that there's, difficulty getting blood through a blood vessel, that's gonna be useful, whether it's in the brain or other parts of the body. And then my second comment is just that in general, patients with blood vessel problems that make them kind of too narrow or often benefit from heat therapy. So like you'll hear that, the claudication or leg cramping gets worse in the cold, but improves in warm weather. And so, I've had families that have literally moved because of this, because they found that warm weather was just better for their kids' overall comfort.
Thank you so much. That's very helpful because he's having a lot of leg pain and we're doing physical therapy, and it was the physical therapist who kind of noticed some things that led her down that path. So this is very helpful, and maybe we'll move to Florida. I like Florida.
Awesome. All right. Any other questions?
Hello, Dr. Rachel. Thanks a lot for
Hi.
the lovely presentation. It was very informative. Yeah, I have a few queries. Like, can you please expand on the neuropsychological evaluation which you talked about, and what is the best age to do it? And
Yeah, that's a great question. I don't think there is a perfect age to do it. I mean, and again, I don't necessarily think that it's necessary in every kid, but I think if, starting around school age, so 5, 7, if there are challenges in school that are not exactly clear what's going on, it can be helpful. I mean, first starting with your pediatrician, there are some basic assessment tools they can do to screen for anxiety, ADHD, depression. Those things can often look pretty similar and have a lot of overlapping symptoms. And then if they're not able to kind of identify the issue, doing more formal neuropsych testing can help kind of get at your child's specific like learning differences. And then oftentimes that helps guide interventions that can, work on that particular domain. Does that answer your question?
yeah, doctor, thanks a lot. And doctor, another thing was like, so I mean, the pediatrician is the best to decide like whether the child should be going for the whether he or she needs a neuropsychological evaluation, or
I
all
generally
should.
Yeah, I generally say, the pediatrician is the first line doctor for everything, but in particular, the first pass for screening for developmental differences, learning differences, autism, anxiety, ADHD, but also if you have a neurologist, involved, often they will comment as well. Generally, it's very, institution dependent, whether neurologists, like how involved they are in kind of helping with kind of the behavioral side of things. But if you have a neurologist involved, then it's definitely worth talking to them as well.
Okay, doctor. And doctor, the NSAIDs are to be avoided only like in kids who are already on aspirin, or like even with all phase kids, like do they have anything to do with NSAIDs?
Yeah, great question. So, there's no evidence to suggest there's any problem with NSAIDs in FACE syndrome. So in general, I think it's completely safe, but I just caution that if the kid also is on aspirin already for their FACE syndrome, that I tend to say, like, if the kid has a fever or aches, to use Tylenol as a first line pain med as opposed to an NSAID. But again, it's probably safe to use sparingly while on aspirin. I just want people to avoid it, like using it, several times a week or something.
Thank you, doctor. And doctor, you also mentioned something about CGRPs. Like, can you please tell what are they? For the
Oh, yeah. Yeah, so they it's a newer type of migraine treatment that that there's like, I don't even know how many at this point. They basically some of them are just like monthly injections actually, or medicines that you can use on a less frequent than daily basis. And they work on kind of the blood vessels a little bit to help treat migraine. And they generally are only able to be prescribed through a pediatric neurologist, and generally a pediatric neurologist with special like headache training. So again, probably only available to you if you live near a major metropolitan area, but worth exploring.
Okay, doctor, thank you. And doctor, the magnesium and the riboflavin and the melatonin which you talked about, are they also like helpful as a prevention, or they are only meant for people like who have the headaches as a part of PHACE? Like,
Great question.
As a preventive measure also?
Yeah, I mean, I think that I'm usually seeing patients once they've already had started to have symptoms, and so I would say that I don't know that everyone would benefit from being on those things, but I think if headaches, we know that headaches are very common in PHACE syndrome, so I think if a kid even starts to have occasional headaches, it could be helpful to start magnesium and or riboflavin just to help decrease the frequency of headaches. But I don't know that we have any data on whether starting it before anyone has ever had headaches does anything to kind of long-term affect the development of headaches. So, but the reason that I like magnesium and riboflavin is that they're really safe, and there's really minimal downside other than the cost, I suppose, and having to take a vitamin. But they come in gummy form, so many kids are excited to take them. Magnesium also helps to treat constipation, so a lot of kids have constipation, and it can be kind of like to kill two birds with one stone, can be helpful for those things.
Okay, doctor. Any specific age to use them? Like,
safe in all ages. I think, in very young kids, I probably wouldn't use the exact doses that I suggested, but in kids who are 5 and up, I am using like magnesium 400 milligrams, no problem.
Okay, thanks a lot, doctor. Thank you.
Yeah.
Thank you. All right, any other questions before we move on to our next speaker?
Thanks for having me, everyone.
Dr. Vassar, thank you so much. It was really nice to meet you as well. And I'm sure that we'll have you more involved with our organization. Thank you.
Would love that.
Awesome. Okay, we have Dr. Anna Kerr is up.
Hello, everyone. And Dr. Vassar, if you can maybe unshare your screen. Thank you. Right. So I am Anna Kerr, and I am a researcher at Ohio University, and I wanted to share with you some of the research that I have been doing that is relevant for PHACE syndrome. A lot of my research spans a lot of different vascular anomalies, and what I do is considered social science research. And so I thought I would tell you a little about what I've been working on and some of the ongoing projects that I hope that you and your family or your children might consider participating in. Oops. So a little about me. This is me and my daughter, Penelope. She's 16 months old. I was born with a venous malformation, and so I have navigated a lot of uncertainty and misdiagnosis and mistreatment. And as I was pursuing a PhD in communication, I became very interested in family communication about illness and how we make sense of illness, uncertainty, and illness experiences. And then now, as a professor at a medical school, trying to equip future physicians with the skills to talk about uncertain conditions and help families with rare conditions navigate a lot of the uncertainty that they're going through. And so a lot of this is rooted in my personal experience. conversations I'd had with my parents as I became an adult and hearing their experiences of trying to find a diagnosis at a young age. And so I wanted to explain first what behavioral and social science research is. This is the definition that the NIH gives, where when we look at behaviors, we're looking at the actions of individuals or groups and things like knowledge, attitudes, beliefs. So for me, things like how do your attitudes about the world shape your communication, and how does your communication with other people shape that as well? Social is then those interactions between people, between institutions and systems. And then of course, health being not just the illness, but also the social, physical, and mental well-being of a person. And so my research really focuses on illness uncertainty. And this is kind of the core of where all of my questions that I ask about experiences lie. And we consider illness uncertainty to be this inability to make sense of illness-related events or health-related events. And we tend to say that uncertainty is highest when things are unpredictable or ambiguous or complex. You're probably very familiar with medical uncertainty. This is things like diagnosis, symptoms, treatment, prognosis. But as you all know, we navigate more than just medical uncertainty when we're navigating the healthcare system or trying to get a diagnosis. Personal uncertainty refers to uncertainty about our identity and the roles we play in our life. So being a parent, being a sibling, maybe how this is going to affect another child in your family, things like finances, taking time off of work to navigate medical appointments and having to coordinate all these systems. And then social uncertainty, thinking about the potential for stigma in interactions and how will other people react to me when I go in public, rejection, isolation, talking with young adults about their desire to have romantic relationships. And so we try to have this conversation with physicians and parents and patients of that all this uncertainty is really interwoven, that it doesn't exist in isolation. And so some of the questions that I've asked in the research that I've published and some of the funding that I've got are questions that aren't necessarily predicting biomedical structures of an illness, but asking what sort of uncertainty are parents and patients experiencing? When you're facing medical decisions, what role does uncertainty play and what factors can improve decision-making? Things like how does communication with specialists during that first visit shape uncertainty? And what are some ways that we can improve that visit to really help as you're navigating this kind of vulnerable time? Some of the work I've done, like I said, on stigma, and this is what I'll focus on today, I'll do a deep dive on this study specifically, is what memorable messages do parents of children with vascular anomalies receive and how do we respond to them? And then what does that do for us as we are navigating and adjusting to an illness? My colleagues and I have looked at pathways to care. So when families are affected by vascular anomalies, what are some of the barriers and facilitators? What are the things that get them to expert care? And what are some of the obstacles that they face? One of the things I always like to ask in every interview that I do, and if you've done an interview with me, I ask what advice you would give to other families or to clinicians. And we learn a lot through advice because it's these things that we should be doing or things that we could do better. We've looked at how physical and mental health are affected by communication with physicians, and then what role primary care physicians can play, as a lot of folks have alluded to. They're the kind of the entry point, and how do we make them a really valuable member of the team? So on this slide, this is a really kind of high level overview of the results of these studies. These have all been published. So if you ever want a copy of this, I can share them via personal email. I'm happy to send a copy of them if you're having trouble accessing them behind a paywall or something like that. And some of them you'll find on the FACE syndrome community website. So in the first one, right, we found that those social and personal uncertainties are really multi-layered and complex, and they ebb and flow. So medical uncertainty might go down, but now this opens new uncertainty about school and coping. In study 2, we found that as you're navigating care, we face information and uncertainty dilemmas, often arising from the complex nature of multidisciplinary care. So who do I see for what? This big team of people walks in. And that we talk about autonomy and decision-making a lot, right? We teach our medical students about that you need to give people power to make their own decisions. And hearing frequently of, sometimes I don't know the right decision and I need a team of doctors who are going to help me understand what a good decision means for me, and that they're going to partner with me and not just say, here's all your choices, pick what you'd like, right? That you want that person who will guide you through the process. In the other study I mentioned, we talked about that uncertainty is not necessarily reduced when you're living with a condition that is rare, but finding a team of physicians who make it more tolerable and manageable and you know who to call and it's not as scary, that's the goal. And so making sure as clinicians understanding that it's not just giving all of the information at one time because that can be overwhelming, but talking about when we can give information and scaffolding it and having those conversations with families about where their level of uncertainty is and how they feel like they want to manage it. Study 4, I'll jump into more detail in a minute. Of course, parental advocacy and social support came up as very significant factors in accessing care, right? And these are things that we know that as parents, you are fierce advocates for your child's healthcare, but there needs to be more things in place to connect people with expert care, especially as Dr. Vassar alluded to, that when it's in these multidisciplinary centers that are in large metropolitan areas, how do we make sure that there's more access for folks who are living all over the country and across the world? This is probably common for you. Advice to families: advocate, connect with social support groups like the FACE syndrome community. Study 7, we found that poor information exchange with doctors is affecting physical and mental health outcomes. That patients who reported they were getting poor information, incredible information, that it was inconsistent, were reporting poor physical and mental health outcomes. And then finally, we just published a study looking at those primary care doctors, and parents were really reporting 4 different roles their primary care doctor played. Often they were disregarding or interfering in care. And this really furthered that divide between primary and specialty care, where a lot of patients were saying, I don't even go to my primary care doctor anymore. Where when we saw these supporting and facilitating behaviors where the primary care doctor felt like they were part of the team, they were showing a genuine interest and a commitment to helping, and then patients were continuing to see their primary care doctor when they needed. And that's really the goal, right? Is to have that ongoing whole person primary care alongside the specialty care. So like I mentioned, I wanted to jump into more depth in this study. I talked with Maureen about, what might be some valuable information, and this one really resonates with me personally. I am someone who I really can't go throughout the day without somebody asking if I have a bruise, if I had my wisdom teeth out. It's these little questions, these intrusive requests that I get from someone where I'll just be shopping with my daughter, and then it's just a reminder of, oh yeah, I have something that people aren't familiar with that's rare that I then have to explain. And so in this study, we surveyed parents of children with any vascular anomaly and asked them what sort of messages they had received. And our goal was to look at these feelings of stigma that might be attached to these messages that we're getting just in the world around us. And as a communication scholar, I look specifically at this enacted stigma, so these outward acts, but also felt stigma, so that you might not be actually getting stigmatized or receiving those messages, but you feel it when you walk into social situations. And then as parents, we don't often talk about the felt stigma or the courtesy stigma you get, that you might experience stigma on behalf of a loved one who is experiencing these stigmatizing messages. So like I mentioned, I'm a communication scholar, and so I really focus on that our identity and our self-worth are not existing in isolation. They are shaped in part through our interactions with others. And so as we think about how we can raise our children to be confident and feel like they can go out and be proud of themselves in the world, thinking that these interactions they're having with others are going to shape a lot of that meaning for them. And so memorable messages, this research paradigm, but hopefully this resonates with you, it's these sticky messages that layer, linger, and influence your self-concept. And we tend to get them in these transitions in life. So when you're starting college, you might have gotten advice from a mentor, or there was somebody you met on campus who said something to you. When you were starting your first job, when you were going to summer camp for the first time, or when you were becoming a parent, right? There are these messages that often come from someone, and they shape how you do things or the decisions that you make. And we often think of them as positive messages, right? I'll never forget when somebody told me this, and it made me proud of the work that I was doing. So I wanted to see what sort of memorable messages I had experienced, and if there was consistency across other groups of families. And so this was the prompt that I gave to folks. I encourage you to think about this as well, as it's on the screen. So memorable messages are verbal statements that have been told to you that you remember almost verbatim for a long period of time that have stuck with you in some way. Think about a memorable message that you've received from others, family, friends, providers, strangers, about you or your child's vascular malformation, overgrowth, or physical differences. and then write down the memorable messages you received. The goal is to do your best to write the message word for word. So I asked parents to write these messages for me, and I collected a bunch of them to see what was happening. And then I asked them to say, you know, was this positive or negative? Why did you consider it to be memorable? How did you respond? So that we could really understand, when you think to that social and behavioral research, how are we interacting in the world, and how is that shaping what having a vascular anomaly means for me, for my child, for my parent, or my loved one. So this is what we found. We had 73 parents and received several hundred messages that they reported. You could report as many as you wanted. So some parents reported up to 5 or 6 messages. They were from a wide variety of individuals, strangers, family, clinicians, a colleague or an acquaintance, and then friends. And a lot of them happened in public. And interestingly, most of the messages that were shared were negative. And I didn't ask them to just give negative or just give positive messages. They were able to share any message that they thought was important and was sticky. And they reported overwhelmingly negative messages. And so what we learned in this was that a lot of people get these messages in their life, but when you have uncertainty about your health or your condition, responding to these messages from strangers or from others that you trust is very difficult. So it created this moment where you're caught off guard, or you don't know what to say, or you feel surprised. And so how do we respond to this? So this is an example of some of the messages that were shared. Some of the stigmatizing messages were, you know, does she have that because of something you ate while you were pregnant? So putting some blame on the parent. And this parent said, I was too stunned to say anything, right? There was no comeback, there was no explanation, there was no education. And then just side comments like, oh, poor kid. And the parent saying, I didn't say anything back because I really didn't know what to say. And so in these moments when we're feeling vulnerable or uncertain, these messages can be incredibly intrusive. And then we also don't know how to respond because they trigger that emotional reaction. But we did receive validating messages, which were wonderful to receive. Things like a stranger coming up and say, I know about hemangiomas. Your daughter is beautiful and has a great mom. And this mom shared that they cried profusely and felt a sense of peace and calm because it provided relief during this time where they weren't sure what the diagnosis was. And they were adjusting and sometimes feeling fear to go out in public, and getting this message was incredibly validating for them as a parent, but also for their child. And another person said, it's part of her. Don't worry about covering up. It makes her who she is. And similarly, this parent said, I swelled up with emotions. I was so happy, proud, relieved. And so these pleasant messages, when parents were used to receiving negative messages, created a bit of a perspective shift and often helped facilitate effective coping. So overall, we had positive messages that really can help validate someone else's identity or help internalize feelings of acceptance and support. So I might know I'm accepted, I might know I'm supported, but I get this validating message that really reaffirms that and internalizes it. The neutral ones were ones that I think other people thought were seemingly innocent inquiries, but they reinforced stigma or fostered a fear of public situations for the families. So somebody might not have been saying anything mean, or they were just asking what happened. But when it happens repeatedly, I know for myself, I think, oh, I'm going to go to the grocery store and I have my hair in a ponytail. They're going to ask about it and it's going to be annoying and frustrating, right? It's just they build on each other, that frustration. And then, of course, we receive those outwardly negative messages that express blame, or they threaten the self-esteem of somebody because of physical differences. So the negative or neutral messages often force you to respond to what we call these kind of spontaneous, unplanned sharing. So if somebody asks you a question and you weren't planning on telling them that you had a healthcare condition, you know, why are you eating a certain thing? Why are you not avoiding the situation? Unplanned sharing can be stressful, especially when you're not even sure potentially of your child's diagnosis or what's causing the physical thing to begin with. And so we found that those unplanned sharing, when it's forced, can be stressful and emotional. And so one thing that we try to recommend is preparing yourself and your child in advance to respond to these messages in a way that minimizes the feelings of stigma for you. So what's going to make you feel good in that situation? Is it educating the person? Is it just a nod and the continue walking? But the more that you can kind of have a script in place, when those emotions arise because of that negative message that you get, you'll often then feel prepared and it will just become second nature to respond. So when we think about managing stigma, interactions with others can be stressful. If we feel stigmatized, we'll often engage in things like covering, passing, so trying to act as if you don't have the condition, isolating or avoiding situations, joking, often self-deprecating humor, apologizing or minimizing your presence in social situations. And of course, we don't want these things to happen for our children. And so what can we do to support them? Of course, expressing unconditional love, that it's never a question that my family feels stigmatized or is judging me. Modeling acceptance behaviors. So, I always say I like to put my hair down to go in public, often to do a covering thing. And it's great when my mom will say, oh, you look great with your hair in a ponytail, or you should wear your hair up today. Again, it's not an explicit thing of I accept you, but it's saying you should wear your hair up if you want to wear your hair up. So that's the next one. Encourage them to display the attribute. Educating others about the condition or symptoms, often seeing your parents just say, oh, it's face syndrome and this is what it means, or this is a hemangioma and this is, she was born with it. Some of those ways of educating can be very powerful. And then, like I mentioned, preparing them for how to respond to strangers. Of course, not all support is helpful. You can probably think of times when someone tried to be supportive, and by doing so, they often created more hurt or they created more work for you. And so sometimes when we receive too much social support, we can feel like we're being protected, but in a way that's isolating us and those feelings of stigma. And so what advice do I have kind of broadly from myself to other patients and to other parents is it's okay to feel mad, sad, angry, guilty about interactions that reinforce stigma. I'm 38 years old and I still get these on a daily or weekly basis. And it's okay to feel like this is so frustrating. I wish I didn't have to do this. And so following your loved one's lead, if they feel like they want to take the time to educate and go above and beyond, great. If they prefer to just say, I was born with it and walk away, choosing how they respond. And then also if they feel really frustrated, trying not to say, oh, that person didn't mean anything by it, or I'm sure they were just asking, to avoid both minimizing and overreacting, and really following their lead of how they're responding is really helpful. Ask your loved one how they want you to respond to others. I remember saying to my mom, stop rolling your eyes at that person, or don't get mad if they ask. And so asking your child or your loved one, how would you like me to respond in situations if somebody says something, and just having that open conversation is really beneficial. All right, again, embracing opportunities to talk about the interactions. If you notice something happens in public, to not just pretend it didn't happen and say, how did that make you feel? What do you usually say at school if somebody says something like that? And then including other family members in the conversation if they're present, so that siblings know how to respond if somebody asks them. Having this family conversation and kind of normalizing it and addressing it can help prepare the entire family for these interactions. And then as our children are growing up, and even for myself, acknowledge the stress of new people and new environments. I remember thinking of what side of the classroom am I going to sit on when I go into my new algebra class? How am I going to wear my hair on my first day of work as a professor? What am I going to wear when a new group of students come in? Am I going to tell them about it on the first day? A lot of these things are questions that will just ruminate for a long time. And so acknowledging the stress of new people and new environments can equip you to walk into that situation feeling prepared. And just a reminder, it's exhausting responding to comments, constantly engaging in this process of identity management and how am I going to respond to people today can be exhausting. And so getting the validation and understanding that it's exhausting is very validating. And so providing unconditional love doesn't mean sheltering your loved ones from social situations, but it's equipping them with the communication and coping skills to thrive in many environments throughout their life. So that was a breeze through one study. I want to take you in depth. This is a list of ongoing and future studies that we have. We are currently recruiting for our fertility and family planning study. So talking with women who have decided not to get pregnant, they want to get pregnant and have struggled any way in which FACE syndrome or other vascular anomalies have affected decisions related to fertility and family planning. We have a care coordination study that is ongoing. Dr. Siegel and I just submitted for a journey mapping project that we're really excited about to hopefully document some of these in an interactive website. My colleague Brian Sisk and I are working on some electronic health record and artificial intelligence chat GPT programs. I'm always interested in improving adult care and how we can make sure that that transition to adult care is better. And like I mentioned before, I'm always working on physician communication training and how to equip clinicians to care for patients in these largely uncertain and often ambiguous situations. So that was a very quick overview. Thank you for having me today, and I'm happy to answer any questions if you have any.
Amazing. Amazing. Such good information. Thank you, Anna. Oh my gosh. Okay, what questions do we have for Anna? I know it's always hard to be the last speaker of the day, and we ran over, and I understand that, but I just feel like your presentation will be so great to share with other families. And I think that your presentation is obviously well beyond, just face syndrome. So I think everybody, those sticky messages, oh boy, we all have them. So I think it was amazing.
Wonderful. Well, thank you all so much.
All right. Do we have any other questions? Anything else before we move on? Maybe don't. See if I can. Thank you, Anna. I appreciate it. You have fun with what you're doing today. And thank you for taking the time for being here. Okay, so I just want to thank everybody for coming. I know it's hard to give up your day, and I appreciate it very much for you. Again, another shout out and a thank you to PHACE for sponsoring our meeting today. A couple things I want to plug is the Race for Face. Anna and Buneo in the beginning, she had mentioned Race for Face. This is our annual fundraising. It's our very large fundraising event. We are asking families to consider being a team captain and hosting a race in your area. We can talk you through it. It does not have to be a big, huge 5K timed race. It could be something as simple as grabbing your friends and family and walking through the neighborhood. But we have two, well, I know we have more races confirmed, but we have Chicago. So if you're in the Chicago area, we encourage you to participate in the race with the Perry family. And that's Ryan's Eagle Scout project. He's a freshman. If he can do it, everyone can do it. And we also have Jeannie. She is organizing the race in Virginia as well. So I think we'll have other states as well, but we would love to get your neighborhood on the map. I will be sending out a follow-up email, of course, with a lot of information, and some of that will be about the Race for Face. And so I really am going to ask for people to consider that. And if you don't want a team captain, we also are going to ask you to do a virtual race. And so you could just do anything. You could run on your treadmill, run through your neighborhood, and then just still support the organization. Okay. Next, we have this great picture because we have a huge announcement to make. And because you're on this meeting, you have a chance to be the first ones to know that our next national conference is going to be in Boston, June 20th through 21st, 2025. So save the date and details will be out soon. We are super excited. This is actually hot off the press information. And so that you are all now privileged to know where we're going to be heading for an in-person meeting in 2025. So thank you. All right. Do we have any other information or anything else that we wanted to share? Let's just check the chat. Lots of kudos to everyone. Wonderful. All right, everyone, thank you. Thank you so much. I want you all to have a great rest of your day and a good weekend, and I appreciate you all for being here today.
Thank you so much, Maureen.
You're
Thank you,
welcome.
everyone, for joining.
You're welcome. Thank you, everyone.
Thank you, everyone.
You're welcome, Jane.